Hello everyone.
Hello.
Very good afternoon to one and all. Government College of Nursing Kottayam welcomes you to the webinar organized by the Department of Medical Surgical Nursing, Nutritional Health in COVID-19. On behalf of Government College of Nursing Kottayam, I would like to extend a warm welcome to all of you to the webinar. We value your presence and the time you spend with us. We all know that we are living in the midst of a global health crisis that is COVID-19. As people across the world made through these unprecedented times, there are concerns emerging about what one should eat to meet the dietary requirements and how to boost the immunity. Good nutrition is very important before, during, and after an infection. While no foods or dietary supplements can prevent COVID 19 infection, maintaining a healthy diet is an important part of supporting a strong immune system. Critical illness can contribute to malnutrition in various ways. Inadequate dietary intake due to critical care interventions like mechanical ventilation and increased nutritional demand due to hypermetabolism. Inadequate nutrition has a significant negative impact on critically ill patients, which include delayed recovery, development of complications, and prolonged hospital stay. We also know that in Kerala, lifestyle diseases like diabetes mellitus, hypertension, cardiovascular diseases, liver and kidney diseases, etc., are increasing day by day. The speciality of the above diseases are it takes years to develop, and if occurred once, it is not easy to cure. During COVID times, the persons most affected were those afflicted with lifestyle diseases. They were bothered about getting medications and appropriate treatment during the lockdown period in COVID times. Here comes the importance of nutrition, the medicine for a better tomorrow in preventing and controlling lifestyle diseases. In this context, Government College of Nursing Kottayam is organizing a webinar on nutritional health in COVID-19 with the aim of imparting knowledge regarding nutrition in specific conditions like diabetes mellitus, hypertension, cardiovascular diseases, liver and kidney diseases, and nutritional management in critically ill patients. With immense pleasure, I welcome Dr. Usha VK, Principal, Government College of Nursing Kottayam, the Chief Organizer of the webinar. I welcome you, Madam, to felicitate on the occasion. Over to you, Madam.
Good afternoon to one and all. It's a pleasant moment for all of us that today we are hosting the fourth webinar series from this institution. And this webinar titled Nutritional Health in COVID is very significant topic for the present time. We know that since March onwards, we are facing this pandemic COVID-19 and the people are affected in almost all their spheres of life. And this pandemic is affecting irrespective of age, gender, country, and so on. We know that in this context, nutrition is very important as far as this COVID-19 is concerned. Nutrition as well as hydration. Equally, we have to pay much attention to this two aspects to boost up our immune system and also to lower the risk of infections. And I'm very happy and congratulate the organizers of this webinar organized by the Department of Medical Surgical Nursing, headed by Mrs. Lally Paul and her crew. They have put their lot of efforts to make this webinar a grand success. And so my special congratulations to the one and all in the medical surgical department, medical surgical nursing department. And we have two eminent speakers on this topic, and I really appreciate their willingness to share their experiences, expertization in the area of nutrition concern. Dr. Vinitha V. Nair, who speaks on nutrition in critically ill patients. She's a consultant cardiothoracic surgeon from Caritas Hospital, Kottayam. And my special congratulations to Dr. Vinitha V. Nair, and welcome to our institute. And the next speaker for the day is Dr. Murali A. Is a consultant gastro-surgery and onco-surgery consultant, Caritas Hospital, Kottayam. He is talking on nutrition in specific conditions. Sir, on behalf of Government College of Nursing, welcome you to the topic, to the webinar, and my special congratulations too. So I wish all the success and the very best for the conduct of this webinar. And with that, thank you so much.
Thank you, madam. I am extremely privileged to welcome our esteemed panelist, Dr. Vinitha V. Nair, consultant cardiothoracic surgeon, Caritas Hospital, and Dr. Murali A., consultant gastrosurgeon at Caritas Hospital, Kottayam. Once again, I welcome all the participants who have joined us in the midst of their regular clinical, academic, and COVID-19 containment activities. Participants, please watch the sessions. And if you have any queries or doubts, please type it in the question and answer portal or chat box, which is displayed on the screen. The link for the feedback form will be available in the chat box at the end of the webinar. Please fill and submit the feedback form so that you will get an e-certificate, which will be mailed to you within 7 days of the webinar. Now, let's move on to the first session of the webinar. Dr. Vinitha V. Nair did her MBBS graduation from Government Medical College, Thiruvananthapuram in 2005. She took MS in general surgery from the same institute in 2009. She did her super specialty training, MCH in cardiothoracic and vascular surgery from the All India Institute of Medical Sciences, New Delhi, from 2010 to 2013. From 2014 to 2018, she worked as a consultant cardiothoracic surgeon in the Department of CVTS, Government Medical College, Kottayam, where she performed more than 500 adult cardiac, pediatric cardiac, and thoracic procedures independently. She was an integral part of all 4 cardiac transplants performed in the center during the period, first in a state government center in the country. She got an opportunity for fine-tuning of her training in pediatric cardiac surgery from Boston Children's Hospital, USA, and Hospital for Sick Kids, Toronto, Canada. Since August 2018, she has been working as a consultant cardiothoracic surgeon at Caritas Hospital, Kottayam. With immense pride, I am inviting Dr. Vinitha V. Nair for enlightening us with nutrition in critically ill patients. Over to you, madam.
Thank you so much. Am I audible?
Yes,
Am
ma'am.
I audible?
Yes,
Okay.
madam.
So thank you so much for your kind introduction. And today, you know that this topic, more than the importance of the topic, this topic is a very commonly discussed and debated one. And as you know, there are at least 4 or 5 international guidelines telling about the nutrition in critically ill and various specific conditions. That itself means how important this topic is, and how, and every year updations are being coming on this topic. So I would like to provide a guidelines as per the understanding till this year 2020. And can I start sharing my slides?
Yes, ma'am.
Okay. Okay. Is my slide visible?
No, ma'am.
But 1 second. Host disabled participant screen sharing. That's what it is written here. Can you please enable me to share my screen?
Yes, ma'am. Ma'am, you can share now.
Okay, 1 second. Okay, can you see it now?
No, it's not visible.
Okay. Okay. Now.
Yes, ma'am.
Now
Yes.
it's visible.
Now it's visible. Now it's visible.
Okay. Let me make in the PowerPoint slideshow mode. Okay. Hope it is visible to everybody.
Okay.
Am I audible? Yeah.
Yes, ma'am.
So greetings from Caritas Hospital, Kottayam. We shall talk on the subject of nutrition in critically ill patients. So my outline of the talk will be on malnutrition, the definitions prevailing, basics of metabolism, to introduce you to a concept of prehabilitation and nutritional optimization, importance of micro and macronutrients, a short note about refeeding syndrome, and finally, a guide to medical nutrition therapy as per the current literature evidence. So when you check what is the definition of malnutrition, the Oxford Advanced Learners Dictionary tells that it is a poor condition of health caused by a lack of food or a lack of right type of food. But is malnutrition as simple as Oxford Dictionary tells? Let's see what the medical guidelines tell. The Aspen Guidelines consensus statement states that malnutrition refers to the imbalance between nutritional intake and requirements that ultimately causes changes in body weight, body composition, and physical function. So it's not enough that the person has a decreased intake, but that should cause changes in the body also. Then only it comes under the definition of malnutrition. So the 2012 consensus says that at least presence of two or more of these things is required to qualify as malnutrition. Along with insufficient energy intake, there should be at least one of these, either weight loss, loss of muscle mass, loss of subcutaneous fat, localized or generalized fluid accumulation, or a decreased functional status. Now, the Aspen guidelines and the Academy of Nutrition and Dietetics also say that inflammation is increasingly identified as an important underlying factor that increases the risk of malnutrition and may contribute to suboptimal response to nutritional intervention and increased risk of mortality. And as you know, malnutrition is caused by a multitude of factors and which are overlapping many times. Like sometimes it is socioeconomic when the person has nothing to eat. Sometimes it is a disease or a lack of medical awareness, cognitive impairment, which causes a decrease in appetite, multiple comorbidities, which restricts many type of food from being eaten, psychological challenges, polypharmacy, physical impairment, or inadequate food and fluid intake. So all these leads to malnutrition. And as per the latest European Society guidelines, the nutritional disorders and nutritional related conditions are mainly 5 in number. One is undernutrition, which we usually think of when we hear the term nutritional disorders. The second is overweight or obesity. The third is sarcopenia or frailty. Fourth is micronutrient abnormality. And last but not the least is refeeding syndrome. Now, the nutritional status is progressively compromised over the continuum of care. Because we are all medical personnel, we shall discuss about a person who is admitted in hospital for some reason or the other who faces nutritional challenges. It should be noted that a majority of studies show that 30 to 50% of patients are malnourished upon admission to the hospital. And during hospital stay, many patients, even with a pre-operative or a pre-admission normal nutritional status, experience a decline during the course of hospitalization. And not even that, even post-discharge, weight loss and loss of muscle increase the risk of readmissions. And how does malnutrition impact clinical outcomes and cost of care? It is well known that malnutrition impairs the wound healing, which leads to recurrent hospital admissions, increases the infection, adds to the mortality, increases other complications, system disorders, adds to the cost of treatment, decreases the convalescence, and lengthen the hospital stay of patient. And on the whole, it increases the cost of care and decreases the quality of life. Now, with this background, we can go towards the proper topic of nutrition in critically ill. Before understanding the nutrition and supplementation in critically ill patients, we should understand the basic body composition of a human being as well as the basic metabolism and what is the difference from the normal metabolism when the patient is faced with a stress condition. Now, looking at the body composition, let us take an average weight of a male is 70 kg and a female is 60 kg. You know that two-thirds is made up of water. 42 out of 70 kg in a male and 31 out of 60 kg in a female is made up of water. And the solids amount to only 28 and 28.8 kg respectively. And fat amounts to a big source of these solids. The rest is constituted by proteins and minerals. Now, the term lean body mass is to be well understood. Lean body mass means the body weight minus fat and liquids. So mainly it is the proteins and minerals, or in short, it is the protein of the body, which is called as lean body mass. Now, we have to understand what is the difference between a normal starvation and a stress starvation. Suppose two persons, one person is starving upon his own will for some religious reasons or as a process of decreasing his weight. So one person taking starvation on voluntary aspect, and second person who had an accident or a burns or a major surgery, and he is in the hospital and he is not fed for 7 days. So let us consider these two persons. What is the changes taking place in these two persons? The first, we shall consider the metabolism in the person who is starving at his own will. So when a person is starving, for the first 24 to 36 hours, the blood glucose is maintained by the breakdown of glycogen in the liver. The main biochemical process taking place is glycogenolysis. Now, once 36 to 48 hours are crossed, the glycogen store is depleted. Now, the blood glucose has to be maintained to keep the person alive and all the body organs functioning. So, the next process which takes place is gluconeogenesis. As the term implies, it is genesis or making of new glucose from non-carbohydrate sources. And this non-carbohydrate source is mainly the muscle, which release the amino acids, and also from the ketone bodies and so many other sources, non-carbohydrate sources, which provide the substrate to make glucose. Now, after 4 or 5 days, the brunt of responsibility to provide the nutrients is taken over by the fat, and the process which take place in the body of a voluntary fasting person is ketogenesis. So by about 5 or 6 days, the ketogenesis is the predominant biochemical change that take place in the body of a fasting patient, and this is an attempt to preserve the proteins in the body from breaking down to provide amino acids for gluconeogenesis. So the main energy is given by ketogenesis, and the protein sparing effect comes into view. Now, this is the metabolic response to starvation. The green line denotes the exogenous supply of food. So one fine day, he has stopped having food from outside. So it has come down, and initial 24 to 48 hours, or probably 24 to 36 hours, the major supply is by the glycogen breakdown by glycogenolysis. And after that, the next is gluconeogenesis for the next 3 to 4 days. And at the end of first week, the major change is the conversion of gluconeogenesis to ketogenic pathway. Along with this, the body also, when a person is fasting, the body knows that I'm not getting any food. So the body tries to conserve the energy. So the body decreases its basal metabolic rate. And as the protein breakdown decreases, the nitrogen excretion in urine also decreases. So the net nitrogen balance will be positive or maintained neutrally because of the decrease in urinary excretion of nitrogen. Now, suppose the insult has come. Now we are going to the second person who had an insult. The insult may be anything like a trauma, a burns, major burns, a surgery, or an infection. So he had an insult and now he is into the hospital. Now what happens is some unwelcomed guests also come into his body or are released from his cells. They are the interleukins and the tumor necrosis factor. So as soon as an infection or an insult comes, these agents are increased in the body and it stimulates the body for an elevated energy expenditure and protein catabolism. This is the classification of the response to the body following a stress it is divided into acute phase and a late phase or chronic phase. The acute phase is in the first 1 week. It is again divided into early acute phase and a late acute phase. So this acute phase indicates catabolism, and only in the late or chronic phase, anabolism in the body starts. That is typically after 7 days of forming getting an insult. So in the first 7 days after an insult, the body will be in a state of catabolism. And in this, in the early acute phase, the body will be trying to conserve the energy by decreasing the insulin and decreasing the hormone level by glycogen breakdown. But in the second acute phase, that is from days 3 to 7, the body will be going for an aggressive protein catabolism because of switch on from glycogenolysis to gluconeogenesis. And by aggressive protein catabolism, amino acids are released into the bloodstream to provide substrates for gluconeogenesis. And along with that, insulin resistance also comes. A lot of inflammatory mediators are released, a lot of steroid hormones, the acute phase reactants are also increased in the blood. And this is the phase where we should support the person with nutritional supplementation in order to restrict the catabolism and prevent the proteins from breaking down. Now, when there is hypermetabolic stress, all the stress hormones released will break down all the reserves in the body. The lipid reserves are broken down to fatty acids. The hepatic glycogen is released into glucose, and the muscle amino acids are broken down to provide amino acids for gluconeogenesis. Now, similar to the person we discussed earlier, what is the change happening in this person? The first 24 to 36 hours, yes, this person also has glycogenolysis. The glycogen breakdown occurs, and that is the main source of glucose production in the body for the first 24 to 36 hours. After 36 hours, as in the first person, here also gluconeogenesis takes up, and glucose is formed from non-carbohydrate sources. But what is lacking here is that even after the 4 or 5 days, that is at the end of first week, the metabolism is not shifting from gluconeogenesis to ketogenesis. The gluconeogenesis promotes unabatedly. It continues unabatedly. Why? Because this is a normal cell with a cytoplasm and mitochondria. The glycolysis happens in the cytoplasm. Pyruvate is generated in the cytoplasm. This pyruvate has to enter into the mitochondria to enter the Krebs cycle and finally provide energy to the individual as ATP. But the interleukins and tumor necrosis factors specifically inhibit the entry of pyruvate into the mitochondria, and hence, in a person with stress, pyruvate cannot enter the Krebs cycle. And the second important thing is that the fatty acid, in order for the ketogenesis to take place, the fatty acid beta oxidation pathway takes place inside the mitochondria. The fatty acid formed in the cytoplasm should enter into the mitochondria and get converted to ketone body by beta oxygenation. But the carnitine is an important cofactor in this transport. But the tumor necrosis factor, interleukin 1 and interleukin 6 inhibit the carnitine, and fatty acids cannot enter the mitochondria to take part in ketogenesis in a person with hypermetabolic stress. So two pathways, there is the entry of pyruvate to enter the Krebs cycle and the fatty acid entry for continuation as beta oxidation to ketogenesis, both which take place in mitochondria are inhibited by the inflammatory mediators which are released in a person getting an insult. So this is the major difference. So what happens is the the oxidation of fatty acids cannot take place after 5 or 6 days. Ketogenesis cannot take place, and as the stress continues, the person's gluconeogenesis continues at an exponential rate, and the main source or substrate for gluconeogenesis is the amino acids formed by breakdown of the muscles. That is where we start aggressive. The patient used to get aggressive protein catabolism, and there is loss of lean body mass. And the severity of stress, as the severity of stress increases, you can see the basal metabolic rate goes on increasing, which is highest with severe burns. And as the protein catabolism increases, you can imagine there is extensive nitrogen loss in urine, and the net nitrogen balance will turn towards negative. And these two are also the differences from a person who is voluntarily fasting, because his body voluntarily decreases the basal metabolic rate and protein catabolism so that the net nitrogen balance is positive or neutral in that person. So when we talk of the loss of lean body mass, which refers to mainly the proteins, 10% loss of lean body mass will cause decreased immunity and increase infections, and the mortality associated is 10%, whereas a 20% loss of lean body mass will increase the mortality to 30%. When the person has severe malnutrition, severe protein catabolism, 30% of lean body mass is lost. The person starts develop pressure sores, pneumonia, lack of healing, and the mortality is for 50%. And once 40% of lean body mass is used, that person cannot survive. Death has to occur 100% of patients, and usually the death is from pneumonia, and that may not be because of the lung parenchymal problem, because of respiratory muscle weakness. The person will again go in for re-intubation and ventilator associated pneumonia, and death usually occurs. So even if we tell that the patient has died from pneumonia, the underlying cause of death is not respiratory, but because of lack of nutrition and loss of lean body mass. And here, this summarizes what I told earlier between the difference in metabolism between a voluntarily fasting patient and a stress patient. The resting energy expenditure is very much decreased in starvation as a part of the body's method to conserve energy, whereas in hypermetabolic stress, the energy expenditure is very much, the fuel source is predominantly fat because of ketogenesis, whereas in hypermetabolic stress, it is gluconeogenesis from the protein breakdown. And body protein is preserved in starvation, it's consumed in stress. Nitrogen excretion is decreased in starvation, but it is increased in stress. It is also the same down. Initially, glycogen store are depleted. The same in both conditions. Protein and fat breakdown starts. It's also the same, but switching to fatty acid as a sole calorie source happens in starvation, but it is not happening in critically ill patients, and hence the proteolysis continues unabated, and the patient already has a high metabolic demand. Along with that, the inflammatory immediate as a release and insulin resistance, increase in stress hormones, all lead to loss of lean body mass and adds to complications. I'm repeating these slides 2-3 times because you have to understand this is the basic concept, the basic difference between a voluntary starvation and a stress starvation. Hence, that is the importance why we have to ensure adequate nutritional supplementation during this changeover period after 3 days. Now, coming to the clinical aspect, importance of nutrition in the perioperative stage, we all know that preoperative undernutrition has a higher risk of postoperative complications. They have increased the chance of infections because they have impaired immune function, and the wound healing is delayed, surgical recovery is delayed, and ultimately the cost is increased, hospitalization increase, and decreases the patient's quality of life very much. Now, early nutrition in ICU. The early ICU energy deficit is an independent predictor of Staphylococcus aureus ventilator-associated pneumonia. So before pointing towards the nursing care, before pointing towards the cleanliness of the ICU, we should note whether the patient is adequately nutritionally optimized to combat the infections in the ICU. And high incidence of MRSA is particularly noted in patients who are not having adequate nutrition in the ICU. Now, consequence, as already discussed, impaired immune response, and most important are the impaired immune response and impaired wound healing, which are most important in surgical and medical practice. Now, this term, medical nutrition therapy. What is medical nutrition therapy? This term is given in ESPEN guidelines 2019. The medical nutrition, the normal oral intake of food is not a medical nutrition therapy. If you are giving oral food to a person who is in the ICU, that is not nutrition therapy. It comes under medical nutrition therapy if you are adding oral nutritional supplements to the regular diet, or you are providing enteral nutrition. Enteral nutrition includes any nutrition given to the GIT in the form of tube feeding, jejunostomy, gastrostomy, anything, and parenteral nutrition. So these three constitute the medical nutrition therapy. Now, the basic dictum is when gut works, use it, because that is the one organ that has been given by the God for assimilating and absorbing nutrients. So when that works, use it. That is the basis for enteral nutrition. And why should enteral nutrition be earlier started in the critically ill patients? Because enteral nutrition favors intestinal villus trophicity, because there are lots of villi in the intestinal brush border epithelium. It promotes gut motility and reduces the translocation of bacteria from the gut. As you know, in a critically ill patient, the most common and most important source of gram-negative septicemia is translocation of gram-negative bacteria from the gut into the bloodstream. We know that we have millions of gram-negative bacteria stored inside our colon, inside our small bowel and large bowel. But a normal person is not getting infection from these because the tight junctions are absolutely tight. They are not permitting any bacteria to translocate from the bowel to the bloodstream. But once we stop feeding the person, the villus trophicity or the villi loses its integrity, and the gap junctions, the tight junctions actually develop gaps in between. So they become gap junctions, and through this gap, the translocation of bacteria occur and gram-negative septicemia set in a critically ill patient. So in order to prevent the translocation and keep the tight junctions absolutely tight, you have to start nutrition, enteral nutrition, as early as possible. Except in the very rare situations of contraindications to enteral feeding, like an intestinal obstruction, ischemia or perforation, inability to access the GOT, severe acute pancreatitis, high output fistulas from the ileum or jejunum, a patient in shock with very low BP and multiple vasopressors and severe GI bleed. Except these conditions, it is always mandatory to start enteral nutrition as early as possible. And those patients who have increased nutritional requirements, reduced nutritional intake, and increased nutritional losses should be given a medical nutritional therapy. Now, how before giving the medical nutritional therapy, how will you assess the need of medical nutritional therapy? How will you know that this person needs? So for that, you have to assess the nutritional status of a person upon admission to the ICU or into the hospital. So most commonly and most easily carried out one is uh, who is Jancy has raised a hand. Is it okay? So how to assess? The most commonly used one is, am I audible? Hello?
Yes, madam.
Yeah.
Okay. So no, somebody are raising hands. That's why I'm asking. Okay. Subjective global assessment. Subjective global assessment is one of the most commonly used assessment tool to know the nutritional status of the person who is being admitted to the hospital. As you know, it has a lot of variables, but considering a nutritional therapist or a routine clinical nurse, it is easy to fill in this form because it is very simple, and they can actually, even though it looks very long and too many variables, it's actually very easy, and it's most commonly used in many of the ICUs in India as well as abroad. This okay. Next is NRS, or nutrition risk screening tool, which is developed in 2002. It is also easy and contains less variables than that. So it gives mild and moderate and severe scoring, and each score like normal nutritional status and normal nutritional requirements. So in the mild, score 1 is a weight loss more than 5% in the last 3 months, or the food intake is less than 50 to 75% of the normal in the last week, and then it is allotted a score 1, and normal nutritional requirements are given in these patients. So moderate score 2 and severe score 3, and according to the age, you add 1 score if it's more than 70. So this is another method of assessing the nutritional status of a person who is admitted to the ICU. We also have a MUST, malnutrition universal screening tool, which also goes in a 5-step process, asking these questions about the BMI, unplanned weight loss, and acutely ill, stop nutrition for the last few days, add the scores together, and then categorize into low, medium, and high risk, and then routine clinical care, observe and treat accordingly. And one more score is a Nutric score, or nutritional screening in critically ill patients. The difference in this is that this is one of the very specific scores, and it correlates very highly correlates with mortality, but it doesn't have any of the nutritional variables as seen in the other 3 assessment forms. It takes into account so many other scoring also, like Apache to SOFA, interleukins and all. So it is a little more cumbersome, and it's difficult to be assessed if all these details for Apache, SOFA are all not available, but it correlates highly specifically with mortality. So these are all the various scoring systems which can be used. There is still debate going on as which is the highly specific and highly sensitive one to be followed in the ICU. But till date, there is no consensus on which one is the the most sensitive and most specific one. Different ICUs and different systems use different ones, and most of the Indian scenario use subjective global assessment. NRS is equally good to use, and Nutric score is excellent, but the problem is that it may not be possible in all ICU to get all these variables. So now, how early, once we have assessed with this score and categorized the patient into at risk of malnutrition patient, now how early we should start enteral feeding? All the guidelines, all the international guidelines uniformly tell that you have to start enteral nutrition as early as 24 to 48 hours of admission into the ICU. Now, at this juncture, I would like to introduce the term prehabilitation to you. So you have all heard of the term rehabilitation, physical rehabilitation department. So once the patient is out of an insult, we have to rehabilitate his physical strength and muscle power. So what is a prehabilitation? If rehabilitation occurs after an insult, the prehabilitation occurs before an insult. So to define, prehabilitation is the process of enhancing an individual's functional capacity to enable him or her to withstand a forthcoming stressor, example, a major surgery. So, for example, if a person is going to face a major surgery, and we think that the next week this person's surgery is planned and he will be in ICU, it is not enough that you calculate the nutrition, assess the nutrition on admission to the hospital. You have to prehabilitate. You have to start nutritional screening and nutritional supplementation in the person right from the time a decision is made to operate upon him, maybe weeks before when he is in the OPD. So this term and this concept has been explained by the American Society for Enhanced Recovery and Perioperative Quality Initiative Joint Consensus Statement on Nutritional Screening and Therapy, and is published in 2018. Now, this is a very important slide. So for next one or two slides, it is not about patients in the ICU. It happens when the patient is not even entered the hospital. So the nutritional assessment and nutritional supplementation is not enough that it starts in the ICU or the hospital, but it should start at home or it start in the OPD before the patient gets admitted. This can be planned only if it is a planned surgery. Unless in the case of like a trauma or burns, obviously we can't plan like this. Now, this slide is very important. Say 2 out of 3 patients coming for gastrointestinal surgery are malnourished at the time of surgery. And there is 3 times greater risk of having complication if they are malnourished, and 5 times high risk of mortality. Only 1 in 5 hospitals have a formal nutritional screening process. Even though 3 out of 4 surgeons believe that peri-op nutrition delivery will reduce complications, and only 1 out of 5 patients receives any pre-operative nutritional intervention. Remember, this is a pre-operative nutritional intervention. It is not peri-operative or post-operative. Now, almost all the hospitals have some facility to promote nutrition in the ICU. That is only a peri or a post-operative care. Pre-operative nutrition care is still in its childhood days in our country, and not even in our country, even in a developed country like USA. And this portion is very important. Every $1 spent on nutrition therapy in hospitalized patients saves $52 in the hospital cost. And this is a famous study from USA by the nutrition critical team. So they say if you adequately prepare the patient for surgery, you can decrease the ICU length of stay, you can decrease the complications, and in effect, this $1 spent will translate into a gain of $52 in the hospital bill. So nutritional intervention should start from the OPD. Nutritional risk assessment should start from the OPD as early as a person is decided to undergo a surgery, and it should continue through the peri-intraoperative, post-operative in the ICU, and continue through the discharge orders, and continues through follow-up. You should not stop the nutrition supplementation in the ICU or at discharge, but during follow-up also the patient needs nutritional rehabilitation. Now, this is pre-operative quality initiative nutrition 6. That is, a pre-operative and post-operative nutrition screening are absolutely essential. Proteins are more important than calories, to which we will be discussing in the coming slides. Stop feeding late pre-op and restart early post-operative. There is no need for 12-hour fasting for all cases. You should feed the patient late until 6 hours, 2 hours before surgery, and you should start post-operative feeding as early as possible. Consider nutritional supplementation for all patients to meet up to the protein requirements. First, oral supplementation. If it is inadequate, change to enteral feeding. If it is inadequate, change to parenteral feeding. And nutritional management is a team game. Now, this is a PONS screening or a pre-operative nutritional screening. Before the patient is admitted to the ICU, you should screen the patients with this simple tool. This almost is similar to that of NRS 2002. Step 1, you look at the BMI, less than 18.5. Or in older persons, there is less than 20. Step 2 is weight loss score, unplanned weight loss more than 10% 6 months. And third is intake score. Have you been eating less than 50% of your normal diet in the preceding week? If any one of these questions, you get an answer yes, then check the albumin also. And if the answer is yes, or the albumin is less than 3, the person needs a pre-operative nutritional screening by sending him to a clinic or a dietitian, and then properly working up the patient for nutritional screening, and then planning his nutritional supplementation accordingly. Now, enhance recovery after surgery. It's the components to minimize the stress and to facilitate faster recovery. That is, the IRAS is being practiced in almost all surgical specialties nowadays, and the IRAS specifically tell a pre-admission nutritional support and early oral intake of fluids and solids as soon as possible after the surgery. Now, enteral feeding formulas. Coming to the enteral feeding formulas, there are different types of formulas, which are polymeric, oligomeric, or specialized disease-specific or modular formulas. Polymeric formulas are two types, which are commercial, which are available as supplements, and blenderized, which is simply kitchen feed. And the polymeric formulas contain intact nutrients, and the energy distribution is similar to that of a normal diet, with proteins constituting around 20%, carbohydrate 40 to 60%, and fat around 25 to 40. And most commonly, this is being used for tube feeding. And the difference between a blenderized diet or a kitchen feed and commercially available formula is, commercially available formula, we know what we are giving. It's a complete and balanced nutrition, easy to calculate the protein and calories, and it is commercially sterile, and it will not clog the tubes because it can be diluted as per our requirement. But the kitchen feed is mainly, if we don't have a dietary department controlled kitchen in our hospital, the nutritional content is unknown, and the osmolarity is unknown, and the microbial quality is poor. It is high chance of contamination, and it has high viscosity. Now, coming to oligomeric enteral formulas, oligomeric formulas contain proteins as amino acids, carbohydrates as glucose, and fats as fatty acids and triglycerides. So these are broken down so that the persons with a problem with absorption can directly absorb them without the first phase of digestion taking part in the body is being already done outside, and the nutrition is provided as elemental formulas like amino acids, glucose, and vitamins. Now, further one step down is semi-elemental formulas. Semi-elemental formulas means amino acids are further broken down into dipeptides, tripeptides, and oligopeptides. So that is given in sometimes severely patients with severe problems of absorption, like severe pancreatitis. The absorption mechanism is very much damaged. So in these patients, semi-elemental formulas may be better than giving food nutrient supplementation. And modular formula is an incomplete supplement that contain any specific nutrient, like what we give a protein powder. Like for example, when we give a protein powder, we are giving a concentrated protein solution. So glucose powder is a carbohydrate solution. So it contains any one of the single macronutrient in a dense form. That is a modular formula. Now, so we have assessed the nutrition. We have screened the person, categorized him into low risk or high risk, and we know the supplements which are given. Now, how much to be given? So we have to start the enteral nutrition as early as 24 to 48 hours. So how to calculate the nutrition to be given to the person? The gold standard is the indirect calorimetry. Indirect calorimetry is the calculating the energy expenditure of the person and calculating the protein and calorie to be supplemented based on the energy expenditure of the patient. That is a gold standard method based on the oxygen utilization and the carbon dioxide production. But as you know, it is not possible to measure these values in all the ICUs, and hence this is not practical in all places. So next in line is the predictive equation, like Harris-Benedict equation, where there are different equations for the male and female, and we calculate according to the age and the height of the person, weight, age, and height of the person, and then we calculate the energy and protein to be supplemented. But this also has been various problems. 65% of the times only it is correct. And now the most commonly used and simplistic formula is to calculate on weight-based equation, that is 25 to 30 kilocalorie per kg per day. This also has a lot of problems because a person in the ICU, many times we might not have taken the weight of the person. And we usually estimate by an approximate amount. And then the person, if the person is edematous, it will the person appears to be higher weight than normal, and it may not be accurate in a person who is very malnourished or a very obese. So there are problems in itself of calorie requirement calculation by this formula, but there are studies comparing the calorie provision by indirect calorimetry and using the simplistic formula, and they have found that there is not much significantly much difference in clinical outcomes based on these two formulas, and hence most of the ICUs follow this simplistic formula for estimating the energy needs. Now, determining the protein needs, it's based on the age and weight, and the healthy person needs 0.8 to 1 gram per kg per day, and in stress conditions, it may go up to 2 gram per kg per day, depending upon how much stress the patient is facing. And in a critically ill obese, we can't go on calculating according to the actual weight of the person, because he may be 150 kilograms, and we can't go and provide him 150 gram or 200 grams of proteins a day. So when the BMI is 30 to 40, we aim at only 65 to 70% of the target calories, and we calculate like 11 to 14 kilocalories per kg of actual body weight per day. And if the BMI is still high, more than 40, we calculate the ideal body weight, not the actual body weight. Ideal body weight for male and female, the calculations are given below. So by using this formula, using his height, we can calculate the ideal body weight, and then you can provide the nutrition according to the ideal body weight. Also, protein intake is anyway, whatever be the BMI, the protein is to be supplemented, taking into consideration the ideal body weight per day, not the actual body weight. This is important in critically ill obese persons. Now, this is the ideal body weight is white in color, and the actual body weight is the red colored one. Now, these terminology should be understood. The isocaloric field is when we calculate 25 kilocalories per kg, that 100% is energy administration. It defines the isocaloric field. Now, what is hypocaloric or underfeeding is energy administration below the 70% of the defined target is hypocaloric feed. Trophic feeding. Trophic feeding is a minimal administration of nutrients having beneficial effects to preserve the intestinal epithelium, as I already said, to keep the tight junctions intact, to keep the gut moving, to enhance the immune function, and to prevent the bacterial translocation. Some minimal amount given hourly forms the trophic feed that may not provide the nutrients essentially required for the person, but some feed is going, that is called trophic feeding. Overfeeding is if you feed them 110% above the defined target is overfeeding, and a low protein diet refers to a protein administration less than 0.5 gram per kg per day. These definitions are given in SPINE 2019 guidelines. Now, the role of supplemental parenteral nutrition. So we are talking about enteral nutrition during these times. So we know that the critically ill patient in the ICU requires starting of enteral nutrition as early as possible, as early as 24 to 48 hours. Now, suppose if after starting the enteral nutrition, we are not able to get up to 60 to 70 or 60% of the calculated calories is not met with the enteral nutrition. So what should we do? Should we add a part parenteral nutrition called a supplemental parenteral nutrition, or wait? So to address this issue, this is the largest trial in clinical nutrition practice. It's called EPANIC trial, early versus late parenteral nutrition, particularly in adults. It was published in 2011, and it concluded that the late initiation of parenteral nutrition was associated with faster recovery and fewer complications as compared with early initiation. So according to this trial, they tell up to 7 days, you give only enteral nutrition, and even after 7 days, you cannot reach the target, what you are aiming by enteral nutrition alone, you can supplement with a parenteral nutrition. But another study was published in Lancet telling, inquesting into the role of supplemental parenteral nutrition, but their interpretation was individually optimized energy supplementation with supplemental parenteral nutrition starting 4 days after ICU admission could reduce the nosocomial infection and should be considered as a strategy to improve clinical outcome in patients in ICU in whom the enteral nutrition is insufficient. In this randomized controlled trial, they provided supplemental nutrition from day 4 onwards in those patients whose enteral nutrition could not provide the calculated amount of calories. So there are conflicting data, like supplemental parenteral nutrition should be given after 7 days or started at 4th day. Still the debate is going on. But as per the current available literature till date, we can say that if a person is nutritionally okay, not a very high risk patient, you can wait till day 7 to start a supplemental parenteral nutrition if your enteral nutrition is not providing the calculated amount of calories. But if the person is a very much high risk for nutritional malnutrition and complications, severely malnourished, on a case-by-case basis, you can decide after a meeting, you can decide whether to start supplementation from day 4 onwards. So that is always a case-by-case basis, depending upon the amount of stress the person is handling and the pre-operative nutritional status of the person. Now a word on refeeding syndrome. Now, what is refeeding syndrome? A person who is not being fed, we are starting to feed the person. So starvation or malnutrition, as already seen in the biochemistry slides, the processes taking place are glycogenolysis initially, then gluconeogenesis and protein catabolism. So all this protein, fat, mineral, electrolyte, all these are depleted from the body because of severe protein catabolism. And now we start feeding the patient with a high calorie diet. And there is a sudden switch to anabolism, and carbohydrate is a major source. So whenever there is an increase in the carbohydrate supply to the person, the insulin secretion is immediately triggered. So whenever there is an insulin secretion, insulin is the key factor for anabolism, and insulin will direct these nutrients to various anabolic pathways. So once various anabolic pathways are switched on, all on a sudden, there is increased glucose uptake, increased utilization of thiamine, potassium, magnesium, and phosphorus into the cells, and there is severe depletion of these enzymes, these electrolytes in the plasma. So refeeding syndrome is an absolutely an electrolyte imbalance situation, which is characterized by hypokalemia, hypomagnesemia, hypophosphatemia, thiamine deficiency, and salt and water retention and edema. So the main pathophysiological features are abnormalities of the fluid balance, glucose metabolism, vitamin deficiency, and these electrolyte imbalance, which happens when you start feeding a person who has been malnourished for long periods. Now, the refeeding syndrome can manifest in any way that which you can imagine in any of the systems. In cardiac, it can cause arrhythmia and sudden death. It can lead to congestive cardiac failure, hypertension or hypotension, tachycardia, respiratory compromise, renal issues, neurological issues like paresthesia, paralysis, weakness, seizures. Hematologically, you can have a leukocyte dysfunction, musculoskeletal rhabdomyolysis, and finally renal failure, osteomalacia, and ileus and abdominal distension, not tolerating oral feeds. So many times we have seen that in ICU, a person is recovering from his illness. He's all right. He's about to be shifted out from the ICU to the ward, or about to be discharged from the ward to home. Then suddenly he pops up. This is many of you have might have faced this situation many times, that everything was all right, person was absolutely fine, suddenly he had a sudden arrest. Nobody knows what happened. Such situations are mainly because of refeeding syndrome. You have started feeding the patient, but you have not assessed whether the patient is having refeeding syndrome, and any one of these like arrhythmias or hypotension or tachycardia or pulmonary edema might have caused the death of the patient, but that is because of inadequate management of refeeding syndrome. Now, the NICE guidelines have said that in which patients you should identify or you should suspect refeeding syndrome. The patients at high risk of refeeding syndrome are a patient with a body mass index of less than 16, unintentional weight loss of more than 15% in the past 3 to 6 months, little or no nutritional intake for past 10 days, and already a preoperative low level of electrolytes in the body. These patients, when you start feeding, they will go a very severe risk of having a refeeding syndrome after 48 hours of feeding. And or the patient has two or more of these factors like body mass index less than 18.5, unintentional weight loss more than 10% in past 3 months, and little or no nutrition intake for 5 days, more than 5 days. And those patients who have chronic diabetes, hypertension, heart failure, those who are on medications for long time like insulin, chemotherapy, antacids, or diuretics with severe sodium potassium depletion from the body, like chronic heart failure patients, CKD patients, CLD patients, they will be on polypharmacy, and these patients will have different electrolyte imbalances going on. Now, NICE guidelines also tell how to manage these patients. So once you have identified a patient at risk, immediately before starting feeding, you check the potassium, calcium, phosphate, and magnesium. And before administering carbohydrate diet, administer high dose of thiamine, 200 to 300 milligram daily, orally or intravenously, and start multivitamin supplementation. And in contrast to your starting of 20 or 25 kilocalories per kg per day, you should start a very low or hypocaloric feed like a 10 kilocalorie per kg per day, and rehydrate the patient adequately. Daily monitor calcium, magnesium, phosphorus, and potassium, and slowly come up on the carbohydrate feeding to the target value by 4 to 7 days only. So start on a very low calorie diet, and then monitoring the electrolytes, you go up on your calories. And enteral feeding is also not without any complications. You have a mechanical complications related to the enteral feeding tubes, The gastrointestinal complications most common is diarrhea, metabolic issues, infectious issues are all common when you use enteral feeding. And so far we are talking about the macronutrients like provision of calories and proteins, but don't forget about the micronutrient supplementation. All these micronutrients may be very less in a person who is having a disease, for example, a malignancy, or a chronically ill patient like a CKD, CLD, or a CAD patient, heart failure patient. These nutrients will be very much decreased, either because of decreased intake, or because of decreased absorption, or because of increased requirement which is not being met with. So thiamine is the importance of thiamine cannot be overestimated. You can see that there are various important pathways where thiamine is an absolute necessity. After glycolysis, if the pyruvate has to go towards acetyl-CoA and enter the Krebs cycle, the pyruvate dehydrogenase enzyme requires thiamine pyrophosphate as a cofactor. So similarly, the pentose phosphate pathway also requires thiamine phosphate, and the Krebs cycle intermediate requires thiamine phosphate for the Krebs cycle to complete. So all these pathways will be blocked if there is thiamine deficiency. That is why in a patient who is at high risk of refeeding syndrome, you should first supplement high dose of thiamine and then only start feeding. Otherwise, even if you feed, the person cannot utilize these nutrients to reach the final cycle to generate ATP, and hence they will be accumulated and they will aggravate the refeeding syndrome. Now, don't forget to supplement the micronutrients like vitamins A, D, E, K, B complex vitamins, and supplement calcium, magnesium, zinc, selenium, phosphorus. All this should be included in the dietary prescription along with provision of calorie and proteins. Now, this is a guideline, not a strict guideline, but it's a guide to nutrition therapy. This has been published this year in a very beautiful review. When in the ICU, after so many nutritional evaluation tools, you finally see what is the patient's nutritional status. So you have either a well or a moderately malnourished patient, and you have a severely malnourished patient. So if the patient is well nourished or a moderately malnourished, in the early acute phase we described earlier, that is in the first 2 days in the ICU state, consider to start the enteral nutrition. There is no need to start parenteral nutrition if there is no contraindication to enteral nutrition. And the energy target we are aiming is only less than 70% of the estimated or measured requirements. We are planning at a hypocaloric feed to start with. And protein target is not hypoprotein. Protein target is adequate protein, energy target at 1 or 1.2 gram per kg. So starting on day 1 and 2, start enteral nutrition. No need of parenteral nutrition. Enteral nutrition to reach up to 70% of the required calorie calculated, and protein according to the full calculation. Now coming to the 3 to 7 days, continue your enteral nutrition, and depending upon a case-by-case basis, you can consider supplemental parenteral nutrition. If the person is well nourished or only moderately malnourished, you can probably wait till 7th day to start a supplemental parenteral nutrition. So till day 7, you can continue only enteral nutrition. And energy target is 70, slowly update to 80 to 100. By the end of 7 days, slowly update by 5% or 10% every day, and by the end of 1 week you can reach the fully calculated calorie requirement. Protein target also you can increase to 1.3 gram per kg per day. And in the recovery phase, that is more than 7 days, continue enteral nutrition and commence parenteral nutrition. In this condition, if the patient is well or moderately malnourished, you can start supplemental parenteral nutrition if your enteral nutrition cannot provide 60% of the required calorie calculated. And the energy target should be 80 to 100%, and protein should be 1.3 gram per kg per day. So in order to reach this energy target 80 to 100% estimated, you can add supplemental parenteral nutrition if required along with enteral nutrition. Now coming to a person who is severely malnourished in the ICU. So in the acute phase, definitely start enteral nutrition, but close watch should be there for signs of refeeding syndrome, specifically hypophosphatemia. So the first 2 days, you start with a hypocaloric feeding. As already said, according to the NICE guidelines, you see whether the patient is having a very high risk of refeeding syndrome. If the patient is having a very high risk, just start with 10 kilocalories per kg per day and feed him for first 48 hours. After 48 hours, on the 3rd day of feeding, you check the serum, sodium, potassium, magnesium, and phosphorus levels. A single value of phosphorus less than 3 milligrams per deciliter on day 3 of feeding is diagnostic of refeeding syndrome. And if the person has a low phosphorus and the refeeding syndrome diagnosed, then you should continue to feed only hypocaloric feed for the next 2 to 3 days and correct the electrolyte balance, adequately fluid fill him, and then slowly build up the calories. It is a phosphate is low, keep energy targeted only 50% for next 2 to 3 days. Don't update or upgrade your calories all on a sudden. And from days 3 to 7, you start low and progressive. If enteral nutrition is not able to give the nutrients calculated, you can add supplemental parenteral nutrition, but only keeping in mind that you should not increase the refeeding syndrome. So we continue to watch for the signs of refeeding syndrome. And finally, after 1 week, when you have no risk of refeeding syndrome, you can give full enteral nutrition or supplement with supplemental parenteral nutrition to attain your high energy goals. Now, how do you monitor the patients on enteral nutrition? You have to take a daily weight, and that may not be possible in bedded and intubated patients. You have to check for the development of edema, pre-sacral edema, upper limb, lower limb edema, strict input-output chart to look for how much he is accumulating fluids, vital signs, stool frequency, abdominal examination, and daily monitoring of electrolytes, RFT, renal parameters, and albumin. So these parameters have to be monitored to know how is the nutritional efficacy that we are supplementing to the patients. The post-operatively, our nutritional supplementation does not end with discharging the patient from the ICU or discharging the patient from the hospital. 4 to 8 weeks minimum of post-operative high protein oral nutritional supplementation in all patients having a major surgery, and as long as 3 to 6 months post-operatively in more severely malnourished patients or those with prolonged post-operative or ICU stays. Otherwise, if we are providing high protein, adequate calorie nutrition in the hospital, discharging him without proper nutrition advice to continue his high protein diet, he will come back with another episode of pneumonia or a wound breakdown or some other complication. So even though the wound appears healed from outside, it takes 1 to 2 months for all wounds to heal from inside. So all patients should have a minimum of 2 months of high protein supplements to be advised to take at home even after a major surgery, burns, illness, or any trauma. Now, so to conclude, the take-home message is the concept of prehabilitation should be understood in its full context. That is, the nutritional screening and nutritional supplementation starts not from the hospital door, but before the patient starts from home to reach the hospital. And nutritional screening is absolutely compulsory for all persons, whether it is a surgery, a trauma, a burns, an infection, anything. All patients should have a nutritional screening. Oral nutritional supplementation can be liberally used to make up to the protein. Enhanced recovery should be carried out in nutrition. Proteins are more important than calories, and you can start with a hypocalorie versus an isocaloric diet. Supplementary parenteral nutrition should be provided on a case-by-case basis, and especially in the ICU, beware of the refeeding syndrome and continue your post-operative care even after discharge for a complete recovery of a person. Thank you.
Thank you, madam, for the wonderful session. So there are a few questions in the chat box. Madam, please see the questions.
So shall we answer it at the last, or shall I answer it now? Okay. So just see what are the questions.
Madam, only 3 questions. Madam, only 3 questions.
Okay.
From one question from Dr. Usha VK.
Okay.
What are the types of foods to be included for children who are critically ill with COVID-19?
Critically ill with COVID-19 is basically when the patient is in SIRS or the COVID-19 produces a critical ill situation. It's either respiratory compromised or the patient is in a systemic inflammatory response syndrome. So in such situations, if the patient is going for a severe inflammation and shock, the provision of enteral nutrition is itself is questionable, because the provision of enteral nutrition in a patient who is very sick and shocked needs to be reassessed depending upon the hemodynamic and the vasopressor support. Otherwise, if the patient is only hemodynamically stable, only requiring ventilator for a respiratory compromise, then we can calculate the calorie. The calculation of calorie and proteins for children are different from that of adults. The provision of nutrients are different from that of adults, and it varies from different age groups. So for kids, we cannot tell a common calorie calculation like that in adults. That is a totally different topics. And the type of foods, it doesn't matter what type of foods, but it is the food which will provide adequate protein and calorie. That's what any type of food you can include which will provide adequate protein and calories. And COVID-19 critical ill situation is particularly important when the patient goes in for a systemic inflammatory response syndrome, SIRS syndrome. In SIRS, with high vasopressor support, enteral nutrition should be given very carefully, and even very hypocaloric feeds need to be started. Sometimes we may have to give parenteral nutrition because enteral nutrition may not be tolerated. And for other situations, it is not different. We have to calculate based on the weight and age and the protein and calorie calculation, and accordingly we should provide the nutrients. There is no specific type of food which should be added. And then like vitamins and minerals should be definitely supplied to maintain the boost the immunity and the immunomodulators. So that is, I think, pediatric nutrition is entirely a different topic regarding the calculation and provision of nutrients. So it may be difficult to give a one answer for children as a whole.
Madam, hope your question is answered. Madam, one more question.
Why phosphorus level is assessed?
Jeremiah.
Yeah, why phosphorus level is assessed to diagnose refeeding syndrome? Phosphorus is an important element which is utilized for the production of ATP, adenosine triphosphate. So whatever nutrients we supply, the final end product of all this metabolism comes to the production of ATP. ATP is the storehouse of energy. So when the feeding starts, when a person is to be started on feeding after a prolonged non-feeding stage, the metabolism suddenly switch from catabolism to anabolism. Once anabolic phase starts, there is a massive production of ATP. All these anabolic products lead to production of ATP, and there is a massive production of ATP, and phosphorus is the most important element which is being sucked into the cell for the production of ATP. So the first one and the most important element to decrease in refeeding syndrome is the phosphorus, because it is utilized in so many reactions and so many processes in the bones, in the muscles, and everywhere in the body. So unlike the sodium, potassium, and magnesium, calcium, we regularly monitor, and those are, I think, most of the persons regularly monitor these and supplement these. But phosphorus is the one which is forgotten one, and which is the most important in providing energy. Because of the high production of adenosine triphosphate, phosphorus is the one which is highly intaken into the cells, and that is the one which is depleted in the serum. That's why we importantly check for phosphorus in the refeeding syndrome.
Madam, one more question. Can we expect reduced levels of electrolytes as a part of refeeding syndrome? Can we expect
Surely. The diagnosis of refeeding syndrome is, as I told earlier, a single value of a phosphorus less than 3 milligram per deciliter on day 3 of starting feeding is diagnostic of refeeding syndrome. And the refeeding syndrome, we have a low level of potassium, low level of magnesium, low level of phosphorus, but because of sodium water retention, a high level of sodium, hypernatremia is seen in refeeding syndrome. Now, do we need to supplement phosphorus? Absolutely, yes. We need to supplement phosphorus if the level is below 3 milligram per deciliter. Now, how will you supplement phosphorus? We have phosphorus oral preparations available. IV preparations are not available in our part of the stage, but we have oral preparations available like sachet, Adfos, the trade name which comes in Adfos, and various phosphorus sachets are available. Various vitamins and phosphorus combination tablets are available along with multivitamins. And if these are not available, the easiest method is the phosphate enema, the phosphate enema preparation which we give. The phosphate enema preparation can be given through the rice tube. That gives the phosphorus will be absorbed, but mainly the complaint is it produces some diarrhea, but the phosphorus will be absorbed. So you can, depending upon the phosphorus level, you can give it twice or thrice. The Adfos sachet or the phosphate retention enema can be given through the rice tube twice or thrice a day, depending upon the extent of hypophosphatemia you are having. And after the daily or in severe hypophosphatemia, you may have to check the serum phosphate twice daily, in the morning and evening, so as to know the adequacy of your phosphate supplementation. Once the phosphate level comes to normal, you can see that all the other nutrients are also, all the other electrolytes also come to the normal, and then you can start increasing the calorie of the patient to reach a target goal. So definitely phosphorus would be supplemented if it is less than the required value after starting bleeding. Yeah.
Thank you, madam. There are no more questions in the chat box. So next, we can move on to Dr. Murali A., who is a consultant hepatobiliary surgeon, a trained surgical hepatologist, a surgical pancreatologist, surgical gastroenterologist, surgical oncologist, minimally access and liver transplant, multivisceral transplant surgeon. He is the first hepatopancreatobiliary and liver transplant surgeon in South India and 5th in the country, holding the degree of MCH in hepatopancreatobiliary surgery from the prestigious Institute of Liver and Biliary Sciences, New Delhi, which is the largest liver university in the world. First fully Indian-trained gastrosurgeon to get Fellow of European Board of Surgery degree in surgical oncology. Presently working as gastrosurgeon, hepatopancreatobiliary and liver transplant surgeon at Caritas Hospital, Kottayam. Dr. Murali A. did MBBS in the year 2003 from Government Medical College, Kottayam, MS in the year 2008 from Government Medical College, Thiruvananthapuram, DNB in General Surgery in the year 2012 from the National Medical Board, New Delhi, MCH in hepatopancreatobiliary surgery in the year 2015 from the Institute of Liver and Biliary Sciences, New Delhi, membership of National Academy of Medical Sciences, India in 2007 from the National Board, New Delhi, Fellow of European Board of Surgery in Surgical Oncology in the year 2018. He's a Fellow of Association of Surgeons of India 2018, Fellow of American College of Surgeons 2017, Fellow of Advanced Laparoscopic Surgeons 2018. He is the first Keralite to get the prestigious MCH in hepatopancreatobiliary surgery degree from the President of India, Mr. Pranab Mukherjee, in 2016 January. Sir is taking a session on nutrition in specific conditions. Over to Dr. Murali A.
Hello, good evening. Am I audible?
Yes, sir.
Can you see my slide?
No, sir. No, sir.
Actually, I am using the Vinita's same computer. So,
Share screen.
Okay, sir. Now it's visible.
okay, can I start? Good
Okay,
evening.
sir. Okay, sir.
Okay, good afternoon. Thank you for the kind introduction and thank you for the opportunity. I'll be dealing on the topic nutrition in specific conditions. Greetings from Caritas Hospital. So the outline of my talk is basically, I'll be dealing just like how Vinita has gone. We need to know the basics of the metabolism. So I'll be going little more into the absorption pathways only. The basics she has completed. The basic metabolism, absorption of the macro and the micronutrients, and basically little colonocyte energy and metabolism. And coming to the specific conditions like diabetic mellitus, CLD, cirrhosis, fatty liver, lifestyle diseases like CAD, CKD, aka acute pancreatitis and intestinal failure. I'm not dealing with the lifestyle changes, what is available that everyone will be knowing. So the basic metabolism and how we can approach the nutritional pathways, how we can augment the pathways and get rid of these conditions. So just outline of catabolism, what is happening, the carbohydrate, fat, and the protein which we take after digestion, the fat will be giving the fatty acids and the glycerols, carbohydrates, simple sugars, and the proteins, amino acids. And after catabolism, everything will be coming most towards the acetyl-CoA, and it enters the citric acid cycle and gives the ATP. This is the nutshell of catabolism, what is happening. So coming to the carbohydrate catabolism, the diet, it will be converted to glucose, then it goes towards the pyruvate. As Vinita has told, it get transferred to acetyl-CoA and enters the citric acid cycle for energy. And basically, the single hormone which is responsible for all these is insulin. Whether there is insulin resistance is there, whether there is increased insulin or whether there is decreased insulin. So whether if the insulin is increased, that means anabolism is going to happen. So what happens is like everything goes away from the glucose. That is, glucose will go towards glycogen pathway. Glucose will go towards a pyruvate, and energy building will be happening. So if the insulin is less, then what happens is like everything comes towards the glucose. That's why hyperglycemia happens in insulin resistance and diabetes mellitus. And the pyruvate, as Vinita has told, if there is more accumulation of the acetyl-CoA, it goes towards the lactate and becomes the Cori cycle. And amino acids, it enters the Krebs cycles with intermediates. It cannot give much enzymes, ATPs over here. It has to come out of the Krebs cycle, becomes the amino acids and get converted to pyruvate and becomes the glucose, because around 100 grams, 100 to 200 grams of glucose is required for everyone. For a daily purposes, for RBCs, brain cells, and everything, because we are not taking any ketogenic diet or anything. So some cells and some areas of our body are completely dependent on the glucose. So this is the nutshell of carbohydrate. So what happens in the protein metabolism, whatever you are taking the diet, it will get converted to amino acids, and transamination happens. And through that, carbohydrates are produced, glucose is produced, amino nitrogen glutamate is their acetyl-CoA is produced, ketone bodies are produced. And the important thing is like around 50% of the dietary protein, it is used for making urea. So this is one of the major important pathway what we are happening after taking dietary protein. That's why we are seeing when you give high calorie diet, high protein diet, the urea start increasing. And the lipid metabolism, as Vinita has told, this is a crucial. It can either go towards a ketone body, or it can go towards acetyl-CoA and enters the citric acid cycle and gives the energy. So the immune system in the gut. So there are so many gut-associated lymphoid tissues, Tayer's patches, immunoglobulin A, T and B cells. There are so many cells for getting immunity in the gut. And also, you know that the largest endocrine organ in the body is also the luminal gut. There's so many hormones are being produced, and even we don't know much about these hormones also. Immune system in the gut is one of the important system. That's why the immunomodulatory drugs, medications have come up, nutritional therapies have come up. And the villi, you can see the villi up and down. The vessels usually goes up and comes down. So what happens is like there will be diffusion of oxygen in between. So the tip of the villus will get necrose if there is a splanchnic hypoperfusion. So this is what is happening, the need for a good anesthesia during surgery. When you're doing the surgery, at the time of induction, sometimes the BP can fall. So the splanchnic circulation may come down. So at that time, the villus of this, tip of this villus may get necrose. So the importance of this is like in the perioperative period, these patients are high prone for having diarrhea. So that is the quality of anesthesia is very important while during surgery. The splanchnic circulation has to be maintained. That's why the EROS protocol, like enhanced recovery after surgery, these protocols have come. Coming to the breakdown, if there is any breakdown in the GI barrier, it increases the permeability to the bacteria and endotoxin. That's why sepsis and MODS happen. Vinita told like the endotoxin, translocation of the endotoxin. Usually it's the liver which used to filter all these things. So, but what happens is like when the tight junctions go disrupted, the gut, the immunological action of the gut is lost, and the sepsis or the multi-organ failure will go on. That's why most of the patients whose gut fails, there is a high chance of having infections. So ileus may be one of the important signs of sepsis. Sometimes gastric residual value suddenly increases more than 500 ml. Always think about sepsis. The patient is going to a sepsis. Don't wait for the patient to crash. You have to change the antibiotic. You have to send the culture. You have to hydrate the patient. So you have to think about the sepsis at this point itself when the patient started developing ileus. That means the translocation is happening. So coming to the proteins, the soy protein and the milk protein, most of the nutritional things we use these types of proteins. The importance is like the milk protein, 80% of the time we are using the casein protein and the whey protein. You should know what whey protein is. Casein is a slow protein. That means it's a predominant protein found in the milk, which makes about 80% of the protein in the cow's milk. The casein is a complex protein. The thing is like there is slow digestion of this protein. Whey protein is a collection of proteins that can be isolated from the whey, a byproduct of the cheese made from the cow's milk. It is very important because it's a fast protein. It's a fast energy. So the differences is like the casein protein, there will be slow digestion absorption, and there will be increased gastric emptying time. So there is a more chance of regurgitation. If the patient is having after upper abdominal surgery, his chance of early delayed gastric emptying may be very high. If you're giving casein protein related nutrition, there will be increased regurgitation. So in such scenario, we have to prefer the whey protein. That's why So you should understand the differences of different types of proteins. Then only we will know which protein has to be given at specific situation. So suppose after Whipple's surgery or an upper GI surgery, there is a chance of having delayed gastric emptying. So we need to have a protein which can have fast digestion and absorption and low gastric emptying time, so that the chance of regurgitation is very high. So hydrolysate whey protein, that is easily absorbed. There are different concentrates are available. Coming to the peptides, semi-elemental peptides, as Vinitha told, different types of modules are there, like elemental diets, semi-elemental diets. Elemental diets are only free amino acids. Semi-elemental are the peptides, because up 2/3 of the nitrogen from the peptide protein is absorbed as the peptides. So the absorption pathway of the peptide is little more easy than the free amino acids, because of the there is a peptide PEP1 transport system in the small intestine mainly. The oligo and the ditripeptides are absorbed preferentially than free amino acids. So the evidence shows that in conditions involving the metabolic stress, free amino acid absorption is compromised while peptide absorption remains intact. So this knowledge is being used like semi-elemental diets. We are used in conditions like acute pancreatitis. If there is any malabsorption syndrome, better than elemental diets, you have to go for a semi-elemental diets. So there will be improved nitrogen retention than free amino acids or intact proteins. So when you're giving these whey proteins or anything, you can have better nitrogen retention. That means the absorption will be a little more faster, and it enhances the intestinal microcirculation and increases the absorption also. So it is better tolerated than intact proteins. So if there is any diarrhea, so when you start any enteral feeding, most of the time we are forced to stop it. We think like it is because of the osmolarity, the patient is getting diarrhea. It's not a fact. Most of the time it is because of the other medication. Sometimes you may be giving most of the medication, potassium portrate or a potassium syrup you are giving. It is having very high osmolarity. That may be the cause for sometimes diarrhea. Sometimes add phosphorus supplements may be given. That may be the cause for the diarrhea. Or sometimes you are giving intact proteins. You may have to come down to semi-elemental preparation. So if you're changing the formula from intact protein to a semi-elemental, then most of the time, almost 75% of the time, there will be a resolution of the diarrhea. So the gastric emptying, there are various preparations, and it shows like the whey protein has got gastric emptying time, faster gastric emptying time. So if there is any gastric paresis, then whey-based formulas are preferred. And most of you should think about the essential amino acids, the glutamine, because it's usually decreased after trauma. Glutamine is one of the largest amino acids seen in our body, and it provides fuel for our colonocytes. Basically, it enhances the immune system and the GIT and helps maintain or restore the intestinal mucosal integrity. And the cysteine, it's a rate-limiting amino acid for the synthesis of glutathione. It is one of the important antioxidants. And always you have to think of preparations of branched chain amino acids. These are one of the most important amino acids, essential amino acids. 40% of the essential amino acids are comprised of branched chain amino acids. They are leucine, isoleucine, and valine. The importance is like all other amino acids have got a hepatic metabolism. These amino acids have got muscular, the metabolism is mainly in the muscles. So what happens is like if the patient is having any liver failure, or if the patient is having liver disease, you can give branched chain amino acid, and it competes with the aromatic amino acids like tyrosine and phenyl, the aromatic amino acids, so that the chance of getting encephalopathy in a liver patient is very less. So we can supplement branched chain amino acids instead of aromatic amino acids in hepatic preparation. So the hepatic preparations, when you see, you may have more these antioxidants and more branched chain amino acids. You need around 10 to 15 grams per day branched chain amino acids supplementation. And glutamine, it's the only non-toxic material to induce heat shock protein. The importance of heat shock protein is that it bound proteins, HSP bound protein, are stabilized for survival and repair. Otherwise, it will get denatured. And these are the potential beneficial effects of the glutamine. Like it enhances the insulin sensitivity, critical illness. It preserves the cellular energetic, increase the ATP content, preservation of the muscle mass, and maintenance of the lymphocyte function, and immune intestinal mucosal barrier. So glutathione formation. All these are one of the important steps in our anti-inflammatory action also. So coming to the fatty acid, the energy is around 9 kilocalories per gram. Most of the time it is up to 30 to 35% of the energy usually comes from the fat, mainly from the triglycerides. So there are long chain fatty acids and medium chain fatty acids. You should know the difference. The thing is like the medium chain fatty acids, they are directly absorbed into the portal circulation. That means from the small bowel, it directly goes to the liver. But most of the time, we know like we have learned like the fat, it gets absorbed to the long chain fatty acid, it absorbed to the lymphatic system, it goes to the thoracic duct, it reaches the neck. Then that's why we have extensively, we have learned about chyluria, chylus thorax and everything, the loss of long chain fatty acids. But the medium chain fatty acid, which is more commonly what we are seeing in coconut oil, it's one of the easiest available thing of medium chain fatty acid, triglycerides. The MCT directly from the small bowel, it gets absorbed to the portal circulation, mesenteric circulation, goes to the liver, then it is an easy energy. So in the patients with malabsorptive symptoms like diarrhea, the patient is having pancreatitis, we can supplement MCT along with these peptides like semi-elemental diet. So most of the semi-elemental diet preparations contains these medium chain triglyceride preparations or peptides, oligopeptides, what you're seeing. So you can supplement coconuts. This is the this knowledge we are using in perioperative management. Sometimes in the through the feeding jejunostomy, you may be two participants have raised hand. Am I not audible? Hello?
Yes, sir, audible, audible.
Okay, can I continue?
Yes, yes, sir.
Yeah. Okay. So the medium chain fatty acids, the importance is like in malabsorptive syndromes, it is very useful, and it is a dense source of instant energy. And the carnitine is not required for their metabolism, and it is not stored in the adipose tissue. And taurine is a nutrient. It is a potent neuroprotectant. It protects against the glutamate excitotoxicity, cerebral ischemia. And carnitine, as Vinita has told, it's a metabolism modulator. It is this carnitine which helps the acetyl-CoA to enter the citric acid cycle. Coming to the hospital data, you can see like around 26% of the time you may get non-diabetic patients, and 12% of the time you are seeing very new hyperglycemic patient. The importance is like the mortality, the ICU mortality in these new hyperglycemic patients are very high. So that is the crux. The perioperative period or when any stress comes, the glucose has to be controlled. Previously, persons were going for a very high, tight glucose control, but it's not like from the NICE guidelines, NICE study, which has come like 150 to 180 milligram per 100 ml. The cutoff for the RBS should be between 150 to 180 so that the mortality will be less. So in a diabetic patients or a patients who having sepsis or anything, there is a chance of getting hyperglycemia. And these are the patients who are going to develop complications of systemic inflammatory response syndrome. So we have to control the glucose production. We have to control the glycemic level. So the specific immunity, high glucose level leads to glycation of the immunoglobulins, rendering them inactive, and it decreases the phagocytic potential of the leukocytes. So, and also hyperglycemia can cause for osmotic diuresis, and there will be fluid and electrolyte imbalances. So, regulatory hormone is insulin. So, when there is any critical illness happens, just like what Vinita has told, the counter-regulatory hormones, glucagon, catecholamines, everything will come. So, the insulin will try to decrease the glucose, but the counter-regulatory hormones will try to increase the hormone. So what happens is like in a diabetes or in a trauma or in a critical illness, insulin deficiency or insulin resistance is going to happen. So what happens is like they are going to have more complications. Glycogenolysis will be happening, and there won't be any anabolic pathway. The catabolism keep continuing. The protein catabolism will keep going on. Once more than 40% of the lean body mass is lost, we cannot survive. The patient cannot survive if more than 40% of the lean body mass is over. So what are the major factors in diabetes or a diabetic-like situation? In pre-existing diabetes mellitus is the insulin deficiency. In glucocorticoid therapy, you can have insulin resistance causing for hyperglycemia. And obesity, it is actually the insulin resistance. This is what is happening in obesity, non-alcoholic fatty disease, fatty liver. People are very much worried about the fatty liver. So everything is in the same pathway: obesity, fatty liver, hypertension, CAD, all these things. What happens is the insulin resistance is the root cause. It is because of our lifestyle disease. So what we have to do is regular exercise, and this insulin resistance is because of the our decreased sedentary work style. So adequate metabolism is not happening. So what happens is like the carbohydrates, if it is excess, it has to get converted to either protein or fat. So most of the time it will be stored. Fat is the preferred storehouse of energy. So what happens? It gets stored as a in the liver also, just like adipose tissue. That's why fatty liver is happening. So fatty liver, once it develops, what happens is like inside the hepatocyte, there will be a slow inflammation every time happening, just like a hepatitis is inflammatory hepatitis is being happening. So that is known as non-alcoholic fatty liver disease. Just like alcohol, when you take hepatocyte injury or hepatitis happens, or just like hepatitis B viral infection where hepatitis is happening, with fat also this type of slow inflammation will continue. So that is why we have to be very cautious when you start developing fatty liver, because after 10 or 15 years or 20 years, it can go for a chronic liver disease changes or a cirrhosis. And after some time, probably the NASH will be one of the most common indication for cirrhosis and transplant in the future than alcoholic liver disease. In the older age, because of insulin deficiency, the diabetes is happening. And whenever you're giving dextrose administration, maybe increased glucose production may be causing. In pancreatitis, it is actually the insulin deficiency what is happening. In sepsis, just like trauma, what is happening? There is insulin resistance. That is the same thing. The trauma, sepsis, obesity, glucocorticoid therapy, everywhere what is happening is the insulin resistance. And hypothermia, it's the insulin deficiency. So for the management of diabetes, you need to have definitely medical treatment, insulin or oral hypoglycemic agent, but the nutrition is also very important. Carefully selected food is very important. So we have to correct or to prevent malnutrition. There should not be any hyperglycemia or any hypoglycemia. So there should be a strict glycemic control. So whenever you're doing in the perioperative period, so you have to have 150 to 180 control of the RBS. The balanced food should be there. It contains the macronutrients, micronutrients, and special ingredients, and the calorie requirements. Sometimes disease-specific, diabetic-specific formulas are available, and standard formulas are also. So most of the time in standard formulas, around 15 to 20% of the energy from proteins, 30 to 35 from fat, and 50 to 55 from carbohydrates. So in diabetes-specific one, there will be low in carbohydrate. That is that around 40% will be, and it will be rest will be from the fat and the protein. And the carbohydrate source in the standard one will be high glycemic index carbohydrates. So you should know about glycemic index and glycemic load. So glycemic index, it shows the quality of the that carbohydrate, but glycemic load is more important, like how much it is going to persist after giving a particular feed. The glycemic index is how fast the insulin surge is going to happen, but glycemic load is like for a long period, the glucose surge will be there. So high glycemic load carbohydrates are more dangerous for us. In diabetic formulas, there will be slow digesting, low glycemic index carbohydrates. So that the carbohydrate rise the glucose rise will be very slowly, and the insulin rise will also be very slow, so that there won't be an episode of a hypoglycemia or hyperglycemia, and there will be higher fibers. And the fat source in the diabetic specific formulas are mainly MCTs, and mono or polyunsaturated fatty acids are also there. The proteins also are in accordance with the renal function. And the micronutrient compositions are also, there will be vitamins, antioxidants, and minerals like chromium also. So for the carbohydrates, I told like there will be high glycemic index carbohydrates, that is for instant energy. And for the sustained energy, we need a low glycemic index carbohydrate, and there should be fibers. Fibers, there are soluble fibers and insoluble fibers. The importance is like soluble fibers. What happens is like it can hold the water with it. So what happens is like it can prevent the diarrhea. So if insoluble ones, what happens is like it is insoluble with the water. So that will be forming bulk. So you can avoid the constipation with insoluble ones. The importance of carbohydrates. So most of the preparations are having either maltodextrin or isomaltulose. The importance of maltodextrin is like it is having faster digestion and absorption. So the standard formulas will be having more of maltodextrin, but in diabetic preparations, you will be having isomaltulose because it will be having slow digestion and absorption. So you can see like maltodextrin, the digestive enzyme can easily break the bonds between the glucose molecules, and the glucose is absorbed quickly into the blood. And what happens in isomaltulose is like only very slow digestion happens because digestive enzymes cannot easily break the bonds between the glucose molecules because of alpha-1,6 glycosidic bondage. The glucose is only absorbed slowly into the blood, and so that there won't be sudden increase in the surge of the insulin. So the fiber content, I told high fiber content, most of the time we prefer the soluble fibers. The positively influence the carbohydrate digestion absorption. The most important factor is like some insoluble fibers which our gut cannot ferment or digest. They are fermented by our gut bacteria, and these produce a short chain fatty acid. These short chain fatty acids are the main fuel for our colonocytes. So the fibers are very important for our diet. So adjusting on the fiber content of our diet, we can control our digestion also, like constipation, diarrhea, and everything. And it helps to maintain the GI tract integrity, and it's a preferred energy source of the colonocytes, and it stimulates the growth of beneficial bacteria. And that's why we are giving prebiotics, the concept of probiotics and prebiotics comes in this thing, and it helps to maintain a healthy immune system. Coming to the fat, whether you're having a cardiac disease or a diabetes or anything, you should have a saturated fat less than 7% of the total calories. And the cholesterol should be less than 200 milligram per day. And always restrict on the trans fatty acids. Whenever you buy something, look whether there is any trans fatty acids. If there is trans fatty acid, just avoid it. We are telling like from the markets, if you're buying some chips or anything, they'll be using the same oil again and again, and repeatedly we are using that thing, the chance of trans fatty acid formation will be very high, and they are carcinogenic. So that's why for every time whenever you check it out, always reduce the intake of trans fatty acids. And the medium chain fatty acids are better choice as non-carbohydrate energy source, and also mono and polyunsaturated fatty acids are also recommended. Coming to the lipids, the energy sources are triglycerides, cholesterol, and the phospholipids. And the majority of the fat consumed in the food are in the form of triglycerides, and the triglycerides are made of fatty acids and a glycerol. And this glycerol can go to the glucose pathway also. So coming to the classification, the short chain fatty acid, medium chain fatty acid, and long chain based on the carbon number, less than 6 to 12, or more than 12. The sources of short chain fatty acids, there are milk fats of the cows, sheep, and goat, and the medium chain fatty acids, that is more important, that is from the coconut oil, butter, horse milk, and everything. So coconut is one of the easily available medium chain fatty acid source. And dietary fat, whether it is a saturated or unsaturated. So the importance is like polyunsaturated, you have got omega-6 fatty acids and omega-3 fatty acids. These are the important. Omega-3 fatty acids are very important because they are having immunomodulatory action. So you can see like a omega-3 series, they have got anti-inflammatory action. So that is being utilized as immunomodulatory formulas which we are giving for cancer, oncosurgery, oncology patients, and everything. So what happens with the excess fatty acid supply? So it increases the levels of fatty acids. So free fatty acid, it has to either go to the beta oxidation. If beta oxidation get the Krebs cycle get clumped and it cannot go further, then it has to come out. And either if the insulin is high, it has to go towards the triglyceride pathway. If the insulin is low, that means starvation is happening. So it has to go for the ketone body formation. So the functions of triglycerides are basically to give energy, the protection, nutrition, and insulation, because most of the our cell membranes, sphingolipids, neurological insulations, and everything is formed from the triglycerides. So the digestion absorption is our first emulsification. It goes for a digestion, absorption, and metabolism. So what happens is the long chain fatty acids. So after digestion, it gets converted to fatty acid plus glycerol, and in the intestinal cell, again, it becomes triglycerides. And this triglyceride with some proteins, it becomes the chylomicrons, and that goes to the, we have all heard of the chylomicrons. It's the content of the absorbed dietary fatty acids. It goes to the circulations and initially goes to the lymphatic system. Through the thoracic duct, it reaches the circulation, and through the circulation, it go to the periphery, and endothelial lipoprotein lipase will again make fatty acids, and the fatty acids are being utilized. The rest of the things are coming back to the liver, and then the LDL and the VLDL, that formations are happening. So either the fatty acids, it can go to the fatty acyl-CoA, it can go to the beta oxidation, acetyl-CoA can, it can either go to the beta oxidation pathway, or it can enter the Krebs cycle and formation of ketone bodies. So do all fats behave the same? No. The medium chain fatty acid, I told, it differs from the long chain fatty acids. Very important, because the MCT will directly, the digestion starts in the upper GIT, that is the gastric lipase from the stomach, starts digesting the medium chain fatty acid, and it gets absorbed directly into the portal venous circulation. There is no need for emulsification like long chain fatty acids. So that is important for all the malabsorptive intestinal disorders like celiac disease or anything, along with gluten-free diet. We have to give these semi-elemental preparations like MCTs, and we have to find out which all diet which is suitable for this diarrhea and malabsorptive symptoms. So it is broken down in the intestinal lumen and absorbed directly through the portal venous circulation into the liver, and no lymphatic absorptions are required. That is the importance. And you don't need carnitine. So this is what you are seeing. Like this is the intestinal lumen, the long chain fatty acids. It is absorbed through become chylomicrons. It through the lymphatics, it reaches the circulation. The peripheral tissues, it gives the lipids. Then the rest of the thing, it comes to the fatty acid, again to the liver, and the fatty acid pool is a VLDL is formed. Then again it will go just like chylomicron. It again goes to the circulation and give the lipids. That is a function of the lipids. And MCT, it's an instant energy source and faster digestion, absorption, and metabolism. So coming to the fat malabsorption, there are so many causes. The causes of malabsorption may be abnormal digestion or abnormal absorption. It can be due to bile acid deficiency, because if there is any problem with the enterohepatic circulation, there will be a problem with fat malabsorption. Fat soluble vitamins will be decreased. And if there is any defects in the pancreatic enzymes like chronic calcific pancreatitis or cystic fibrosis, we need to supplement the pancreatic enzymes, and also we have to give a semi-elemental diet. And if there is any defects in the absorptive surfaces also, it can cause for a fat malabsorption. Steatorrhea can happen. And diarrhea, major cause of the malnutrition associated with increased nutrient requirement is diarrhea. So since the medium chain fatty acids are rapidly digested and absorbed, it does not add extra load on the digestive system. And also in the irritable bowel syndrome, the MCT has got a very good role in giving an instant energy. And even ESPEN guidelines, they tell like post-GI surgery and immune modulating formulas in not a high-risk patients, it has got a very good impact, especially in trauma patients. And pancreatitis, I told, MCT, it does not have to depend on the pancreatic lipase. The maximum stimulation of cholecystokinin happens when there is enteral long chain fatty acid. So we prefer medium chain fatty acid. Also, when there is any after Whipple surgery or anything, we have developed chylomicrons or anything. The problem is because of the long chain fatty acid. When you give the long chain fatty acid, the chyle will happen, and this thing will come out through the drain. That's why the chylous nature of the drain fluid is happening. Triglycerides will be more than 100 to diagnose it. So in that scenario, you have to give medium chain fatty acids so that it will not go through the lymphatics. Will give means decrease the long chain fatty acid. Parenteral supplemental TPN parallel nutrition will give. Enteral MCT based elemental diet will give, so that will give the time for that chylous leak to settle by itself, maintaining the energy also. And cystic fibrosis also the same thing. The MCT is a good choice for it. So it is a weapon against fat malabsorption. And because it starts in the stomach, and there is no need for the pancreatic lipase, and it does not stimulate the pancreas also. So MCT supplementation is very helpful in GI conditions like inflammatory bowel diseases, cystic fibrosis, irritable bowel syndrome, GI surgery, and pancreatitis, which are all associated with malabsorption. So you should be knowing why this malabsorption is happening and how nutrients and the nutrition can be adopted for that particular situation. So these are the thing in nutshell in the carbohydrate sources of supplementation which is available. Most of the time I told it's a maltodextrin or a fiber like soy or a fructo oligosaccharides. The fat I told it's most of the time corn or soybean oil or MCTs. And the protein, casein, soya, and whey protein. And you all should know what is a whey protein because most of the preparations we prefer whey in the emerging immediate postoperative period. Coming to the micronutrient absorption, you should know from where all these things are getting absorbed. Like, for example, iron or iron is getting absorbed mainly in the duodenum. So if you're having a jejunostomy, means there is no point in giving. Potassium is also. So most of the time it is getting absorbed from the stomach and the proximal part of duodenum and jejunum. So there is no point in supplementing through the FJ. It has to be given orally. So you should know the exact site of nutrient absorption. The proximal small intestine, the fat, sugars, the peptides, iron, folate, calcium, water, electrolytes, everything will get absorbed. And the middle small intestine, you can have calcium and water absorption. And the distal intestine is very important. Vitamin B12 and the bile salts absorption happens in the ileum. So if there is any distal small bowel resection, there is a high chance of vitamin B12 deficiency. And also after gastrectomy, there will be intrinsic factor will not be produced later. So after this thing, you have to think about vitamin B12 supplementation and enterohepatic circulation. That is mainly almost 95% of the bile salts which is happening. It is circulating in the from the distal ileum. It goes to the liver again. It again secretes to the bile. It comes to the duodenum. Again, it gets absorbed. So that enterohepatic circulation will get disrupted if there is any distal ileal resection. So you should know it. And the colon, the importance of colon is like if around 2 liters of secretions, almost around 8 to 10 liters of secretions are being produced from the upper GI, like from stomach, saliva, biliary secretions, pancreatic secretions, small bowel secretions, and almost 8 liters reaches here, and almost 2 liters crosses the ileocecal valve. And the colon is the area by wise, the water absorption capability is maximum for the colon. At the end of the rectum, when the fecal matter reaches the rectum, the water content is only around 150 ml. That's why when we are reducing the water, the chance of having constipation is very high. And also after right hemicolectomy, what happens is like this bile acids will directly go to the colon because there is no ileocecal valve. So it can cause for the choleratic and toxic bile salts will be produced and it will irritate the colon and there will be diarrhea. So sometimes you have to give bile acid sequestrants at that time if the patient is having diarrhea. So all these things are very important. And another thing is like jejunum. Jejunum is it has got the water absorption capability is not that great like ileum or colon. If you are giving if the jejunals if you are taking some contents less than 90 sodium content, 90 milligrams of sodium content, the jejunum will secrete extra fluids into the lumen. That means when you start after surgery, if you're giving free water or something, because the free water contains less than 5 or 10 milligrams of sodium. So if you are giving less than 90, that means if you give 1 liter of fluid, the end is like almost 1 or 2 liters from the circulation, the jejunum will pour into the intestine. So this is what is happening in a early jejunostomy. Means sometimes you may have stoma, ileostomy stoma. You are giving only 1 liter, sometimes 2 liter will be coming. So that's why in whenever you start feeding or anything through the jejunostomy or anything, you have to give either ORS or high sodium, high salt fluids, not free water. That is very important. Otherwise, the jejunum will secrete extra fluid. So this knowledge of physiology has to be adopted when you manage the postoperative patient. And the same slide, the different parts where all these things are getting absorbed. And this is the fatty acid and the protein absorption. It goes through the lymphatic system and through the thoracic duct and enters the left side of the system in the neck. So the macronutrient requirement mainly in a cardiac patient or a diabetic patient, as per this thing, is the protein should be around 10 to 20% of the energy. As per the European guidelines, and American Diabetic Association is telling around 15 to 20, and the fat should be around 35%. It should be less than, and saturated fatty acid should be less than 7. And always we have to limit the trans fat. And the minimum carbohydrate should be around 130 gram per day. And coming to the micronutrients, it can be macro minerals, micro minerals, or ultra trace minerals. Micro minerals, otherwise known as trace. The macro minerals, their daily need is more than 100 milligram per day. That is calcium, chloride, phosphorus, potassium, and sodium. And micro minerals are trace, that is a 1-to-1 on 100 milligram per day. That is chromium, copper, fluorine, iron, manganese, and zinc. And the ultra trace less than 1 milligram per day, that is iodine, molybdenum, and selenium. So zinc and selenium, they are one of the important trace elements which has to be supplemented in the perioperative period, because it has got very good function in the immunity, in the wound healing, in the anti-inflammatory property, antioxidant property, and the deficiencies can cause for altered taste, diarrhea. There is a decreased muscle capacity, hepatic encephalopathy. Zinc is one of the important element. If there is, because in one of the enzymes, urea cycle, zinc comes as a cofactor. So if there is any zinc deficiency, the patient can cause hepatic encephalopathy in liver patients. So you have to supplement zinc very nicely in a hepatic patients also. And the selenium also, if there is any deficiency, cardiac problems can happen, congestive cardiac failure can happen. But it is also a very good anti-inflammatory and antioxidant. So just a nutshell, the vitamins what Vinita has told, like for everything, before starting surgery, before going for any procedures, or you have to think about the fat soluble and water soluble vitamins, fat soluble A, D, E, K, because the enterohepatic circulation has to be augmented. Sometimes we have to give bile acids like ursodeoxycholic acid supplementation to increase the vitamin and vitamin A, vitamin E, vitamin K, everything has to be supplemented. And vitamin D is very important. Most of us are having deficiencies because we are not going to the sunlight, and vitamin D has got very good immunomodulatory action also, and it can have action in preventing cancers also. So vitamin D is one of the very important vitamin which has to be supplemented. And the thiamine, which Vinita nicely has shown, it has got various function. If it is developing, the patient will be having symptoms of refeeding syndrome. That is one of the very potential things which is happening in the perioperative period. And we need to supplement everything, vitamin C, and because for wound healing, we require it. Vitamin E, it's an antioxidant, which is more given during fatty acid, for fatty liver patients and everything. We used to give vitamin E. And vitamin B12, we need to supplement because one carbon metabolism, we need folate and B12. And vitamin K also, which is required for clotting factor formation also. Coming to the fluid and electrolytes, this thing, you should know like around intake from water, beverages and everything. And there will be some insensible losses also. And through the fecals, we lose around 100. Insensible loss will be around 900, and urine will be around 1,500. And what we take around is around 1.2 to 1.5 liters of water. And from the food metabolism, we may get around 300. And from the solid food, there will be around 1,000 ml fluid coming. And the intake and output almost balances. And there will be around 300 to 500 insensible losses. Always you have to think about that also while calculating the intake and the output. And the daily maintenance fluid should be around 30 to 40 ml per kg per day. And minimum 400 ml of urine is required daily for the excretion of the protein metabolic end products. And I told like jejunal mucosa is leaky to sodium. So rapid efflux of sodium can happen if the luminal solution contains sodium less than 90 milliequivalents per liter. This knowledge of physiology is very important when you manage enterostomy, that's stomas, small bowel stomas. Otherwise, the patient will go for a dehydration and acute kidney injury. Coming to the immunonutrition, there are so many immunostimulating diets like arginine, glutamine, and iron. Even nucleotides, DNA preparations are available. And digestive health, tract health like probiotics, prebiotics, glutamine preparations, and anti-inflammatory preparations like icosapentaoic acid, that is omega-3 fatty acids. And that are favorable prostaglandins, gamma linolenic acid, essential fatty acids, and antioxidants like vitamin C, E, A, selenium, zinc, taurine, copper, and the manganese. All these are having anti-inflammatory properties, and all these together forms the immunonutrition, what we call. But when initially, during the 2000 era, the immunonutrition was considered to be one of the greatest nutritional power. But now, after several RCTs, it's not that much pronounced nowadays. In the cancer, what happens is like a cancer-induced cachexia when compared with the starvation, the lean body mass is lost so fast, because just like what is happening in a trauma, sepsis or anything, that is happening in a cancer. The lean body mass is lost like anything. There will be acute phase response also, because a baseline inflammation will be happening, and protein degradation will be very high. And you have to do something like the omega-3 fatty acids act at this level, so that there's it attenuates the cancer-induced cachexia or the weight loss. That is the action of icosapentaenoic acid, that is omega-3 fatty acids. So there are some indications as per the literature, it's not that great. The evidence, if you see, it's not that great. In critically ill patients, you should not give immunonutrition. There are 4 RCTs telling immunonutrition is contraindicated in critically ill patients. But for patients undergoing head and neck surgery, malnourished patients going GA oncosurgery, and patients with severe trauma, more than 2 body systems got involved, and patients with acute respiratory distress syndrome and mild sepsis, Apache score less than 50. These are the selected patients who can be given immunonutrition if they're going for surgery 7 days before and 7 days after the surgery. But the evidence is not that great, but you can supplement. And coming to the specific incidence of CLD or cirrhosis, what happens in a metabolic abnormalities in cirrhosis? Cirrhosis is almost like because there will be a form of endotoxemia always happening, because liver cannot filter all the endotoxins or the bacteria which is coming to the liver. It will go to the circulation. So what happens is like a small sepsis like or endotoxemia like picture will be there in a cirrhotic patient. So once the portal hypertension increases, this endotoxemia or the hemodynamic profile increases, just like a sepsis. So they will have hyperdynamic circulation. So what happens in hypercarbohydrates? So initially, the CLD will be just like a normal starvation, which Vinita has told, like initial starvation, stress starvation. 2 types are there. For the initial patient, initial stage of the CLD, the patient will be having a normal starvation like picture. 12 hours starving in a CLD or cirrhotic patient is equivalent to 3 days or a 72-hour fasting in a normal individual. So late night fasting should not be allowed in a cirrhotic patient. Most of the time when we give date for an endoscopy or anything, we used to tell like an NPO from 10 p.m. But that is very dangerous for a cirrhotic patient, because we will be doing a upper GI endoscopy, next day morning after 12 hours. So by that time, the patient had almost 3 days of fasting, almost similar to 3 days of fasting. So that should not be happening in a cirrhotic patient. In the fat, what is happening is like there is increased oxidation, carbohydrate, there will be postprandial gluconeogenesis, and fasting, it is deleterious. The protein catabolism increases as the disease progresses. Like the patient will be going for SIRS when the patient's CLD progresses. From child A to child C, when he go, the portal hypertension will increase, and the protein catabolic rate will also be going to increase, and the energy expenditure is also going to increase. And just like a sepsis like picture, that's why we won't have hypertension, because it is good for the heart. In a cirrhotic patient, the BP won't be much higher. And the other metabolic alterations are, there will be, most of the time, there will be increase or metabolic rate will be increased. The patient will have an insulin resistance, rapid postprandial gluconeogenesis will happen, and the glycogen stores will be less. That means 12-hour fasting, it's almost equal to 3-day fasting. That means the glycogen stores are only for, you can fast for only for 6 hours or 6 to 10 hours only. That means in a normal person, 24 hours fasting is okay. Glycogen stores are there. But for a cirrhotic patient, you can fast only for a 6 to 10 hours only. That's why frequent feeding is told in a CLD or cirrhotic patient. So micronutrients, there will be deficiency of the micronutrients. Enterohepatic circulation is derailed. Fat-soluble ADEK is decrease. So what happens is like clotting factors will be decreased. So if the clotting factors are decrease, there is a chance of coagulopathy also, the chance of thrombosis also. And even if CLD is there 1 out of 4, they will develop portal venous thrombosis also. You may think like the INR is high, but doesn't mean like the patient has only the tendency to bleed. It has the tendency to clot also, because the clotting factors which prevent the clotting or fibrinolysis will be absent. So what happens is like the patient can have portal venous thrombosis also. And zinc supplementation has to be high, otherwise the chance of hepatic encephalopathy will be very high. Selenium, magnesium, and all these, vitamin A is also very important, because it can cause for even HCC formation can happen. And if there is what happens is like when enterohepatic circulation has any problem, there will be loss of the micellar formation, and ADEK vitamins will get a decreased absorption, and thiamine and everything will decrease. So they are also prone for developing refeeding syndrome, and there will be a deficiency of calcium, magnesium, zinc, and selenium. So literature tells like 35 to 40 kilocalories per kg you have to give, but most of the time it's not possible to give that much calorie. At least 25 to 30 kilocalories per kg, that's enough for a CLD patient. And the protein, we feel like if the protein is increased, there is a high chance of developing encephalopathy. That is a false notion. The thing is like when the patient develops encephalopathy, you have to decrease the protein. The protein, I told like aromatic amino acid, they are causing the problem. They cross the blood-brain barrier and they cause the encephalopathy. So when the patient is having encephalopathy, decrease the protein to 0.6 to 0.8 gram per kg. And once the patient is out of the encephalopathy, you start with, you increase the protein. That's the where the role of branch-chain amino acids comes. You can titrate, because if the patient requires 60 or 70 grams of protein, we have got branch-chain amino acid preparations. You can give 20 or 30 grams of branch-chain amino acids. Rest of the things only will come. The aromatic amino acids, the level can be decreased, so that the chance of the patient going for hepatic encephalopathy can be theoretically decreased. And the branch-chain amino acids compete for the receptors of tyrosine and other aromatic amino acids, so that they cannot enter the blood-brain barrier also. And hypocaloric versus normal caloric, there is no difference. Even if 60 to 70% of the calorie, it's okay, but the protein needs to be given 80 to 100, and means almost 100% of the protein has to be given. Even acute liver failure, you don't have to decrease on the protein requirement. You can give the 1 to 1.5 gram of protein. And in the renal failure, with and without dialysis, I'll be coming later. And in the hepatic encephalopathy, the proteins has to be decreased, but zinc has to be supplemented. Once the patient comes out of the HE, you have to increase the protein to 1 to 1.2 or 1.5, depending on how much he requires. So in a CLD or cirrhotic patient, we need 3 major feeds, 3 intermittent snacks, and the most important is a late night snack. So the 3 major feeds is a morning breakfast, lunch, and evening dinner. In between, 3 snacks, and 10 o'clock or 11 o'clock before they go to sleep, they should have a carbohydrate late night snack, so that they will have carbohydrate, means glycogen storage. So they should not be fasting more than 5 or 6 hours for a CLD or cirrhotic patient. So there are so many practice guidelines which have come from traumatic brain injury patients. So the guidelines are telling like we have to start the enteral nutrition within 24 to 48 hours once the hemodynamics are stable. The immunonutrition is, the evidence is more in the immunonutrition is for traumatic patients, and you can give omega-3 fatty acids or icosapentaenoic acid preparations. And the proteins, you can give up to 1.5 to 2 gram per kilogram per day, depending on the stress factors. And nutrition in the respiratory compromised patients, if the patient is in volume overload, you can give calorie-dense central formulas. And small frequent feeds should be preferred. Previously, we used to get respiratory, just like a diabetic preparation, respiratory preparation, which were having low carbohydrate, high fat. The thing is like we have, when we are giving too much carbohydrate in a respiratory compromised patient, the chance of having carbon dioxide production will be very high, and the patient will develop tachypnea. So initially that was a thought process, but right now, even the ESPEN tells like high fat, low carbohydrate formulations are not required for ICU patients with acute respiratory failure. And always 60% of the patients who is having respiratory compromise are malnourished. So the monitoring of serum phosphate is very important. They are high prone for developing refeeding syndrome also. And most of the time we used to lose the patients because of pneumonia and loss of lean body mass, because the diaphragm will get exhausted and the patient will not get weaned from the ventilator. So there is no additional advantage of disease-specific low carbohydrate and high fat over standard or high protein or high energy oral nutrition supplement in a stable COPD patient. So these are the metabolic abnormalities, what is happening in a renal failure. In acute renal failure and chronic renal failure with dialysis, there is protein loss. And with dialysis is having more. And the catabolism will be will be maximum in the acute renal failure. In the chronic renal failure without dialysis, the protein catabolism is less and the protein loss is very less. So in acute renal failure, the normal protein and calorie you can supplement. In the chronic liver failure without dialysis, you have to decrease on the protein content, and with dialysis you have to increase on the protein content because the loss of protein is very high. And one more thing you have to think, like a patient who's having proteinuria, asymptomatic proteinuria, they will be losing clotting factors also along with the urine. So they are at high chance of developing DVT in the perioperative period. Always think about those things. And if the patients who are having very high drain output after surgery, like 1 liter, 2 liter coming, the clotting factors need to be corrected because these are the patients who are high chance of having deep venous thrombosis or pulmonary embolism in the perioperative period. And acute renal failure, it can occur as a part of the multi-organ dysfunction and because of a hypercatabolic state. Sometimes once you start feeding high protein diet, what happens is like the blood urea keeps increasing. So we have to hydrate the patient very nicely. That's why when you are taking ketogenic diets or high protein diet, you have to, there will be a high chance of having renal failure if you're not taking adequate fluid. So hydration is very important. Sometimes the patient is having CKD, you cannot increase on the hydration status. So the feed has to be slowly increased. And that's why there will be high concentrated, high calorie type of renal feeds are available. And coming to the nutrition therapy in acute kidney injury, high protein formulas can be given. And the nutritional guidelines, these are the guidelines of the Indian Society of Critical Care, which has come recently in one review article. The standard Enteral formula is recommended for ICU patients with acute kidney injury, and protein should not be restricted with renal insufficiency. In acute renal insufficiency, and the protein can be around 1.2 to 1.7 gram per kg. And in case of a significant electrolyte imbalance, a specialty formulation designed for renal failure should be considered. And low potassium and low phosphate diets can be implemented where corresponding serum levels are high, because there is a high chance of hyperkalemia, and phosphate excretion also happens through the kidney. So you have to be very cautious. And also vitamin C excretion also. So if the patient is having AKI or CKD, so make sure that the magnesium, phosphorus, all these things levels can shoot up. So nutritional therapy in a chronic kidney patient without dialysis, the fluid around 1 liter with the whatever, how much urine volume you can give. And the energy should be around 30 to 35 kilocalories. You need little more, at least 30 kilocalories per kg energy. And the protein should be very less, 0.6 to at least 0.8. You have to keep less protein. Otherwise, the proteinuria will increase. The blood urea formation will increase. And the phosphate, it should be around 600 to 1000 milligram per day. And the formula for short term, you can give standard. And this is, if more than 5 days we need to give, you have to think of some disease specific formulas like protein restricted with reduced electrolyte content. And patients with chronic kidney failure with dialysis, the protein has to be very high. Sometimes you might have to give 2 or 2.5 gram per kg per day. And most of the time we prefer standard preparations for oral supplementation. And if we are planning for any tube feeding, disease specific dialysis formula has to be given. So malabsorption, which contains the inflammatory bowel disease, pancreatitis, irritable bowel syndrome, all these things I told, like semi-elemental type diet with peptides and MCT are preferred. And ORS and sodium solutions has to be given to overcome the jejunal secretion. Always you should think about it. Otherwise, the patient will get dehydrated, and the jejunostomy outcome can increase, and the patient can go for a AKI also. And always for celiac disease, you have to think about the gluten-free diet. What all things the dietitians can help you in finding out what are the gluten-free diet which is available. And also most of the preparations are having gluten-free diet type preparations. And in the irritable bowel syndrome, low FODMAP, that is FODMAP diet means these are a short non-fermentable oligosaccharides, that is fermentable oligodimonosaccharides and polyols. These are the FODMAP. So these types of feeds has to be decreased in irritable bowel syndrome. So in pancreatitis, you can, if the patient is developing acute pancreatitis, at the earliest you have to start the enteral feeding. There is no difference between nasogastric or nasojejunal feed as per the literature. But if the nasogastric feed is not tolerating, you can go for a post pyloric nasojejunal feeding. but you have to try with trial and error. We have to increase and decrease on the enteral feed. At the earliest, you have to start on the enteral feed. If the patient is not tolerating and the diet is less than 60% of the calorie only coming, you have to think about supplemental parenteral nutrition or total parenteral nutrition and give the bowel adequate rest. Short bowel syndrome or intestinal failure, it's one of the important things. If you had to do major resections in Crohn's disease, inflammatory bowel disease, or any vascular ischemic insults have happened, and you have to do major bowel resection, especially small bowel resection, you may have to think about the semi-elemental diets. Polymeric diet is also adequately okay, but always avoid the elemental amino acid diet because they are hyperosmolar, they won't absorb nicely. So always semi-element is preferred. Even polymeric is also okay. And you should give less than 500 ml of free water only. Always think about ORS also supplementing, because the content ORS, the sodium content is more than 90 and glucose is also there. All these can increase the water reabsorption. That's why in diarrhea and everything, we are giving ORS solution. And PPA has to be given for acid suppression. And you have to give sometimes drugs that delay the transit time. That is a loperamide. It's preferred over the codeine, and sometimes antimuscarinics you have to give. There was right now octreotide. We can try octreotide, but the evidence is not that great. If you have to stop it, if there is no benefit in 72 hours after starting. So in some patients it may act, but the evidence is very weak for somatostatin analogs. Sometimes you have to give bile acid sequestrants to decrease the diarrhea. If the enteral is not sufficient, you have to think about the parenteral supplemental. Sometimes if the failure is very too much, like the patient needs to have a completely, patient depends on total parenteral nutrition, you have to think about the home total parenteral nutrition. You can put like a chemoprot or anything. If the patient survival, if you feel like he lives more than 3 months, then you can think about the TP and put a chemoprot or anything, and you can send the patient home and they can take the TPN at home. And if everything fails, the only option will be a liver transplant. With liver transplant sometimes, because if they develop liver complications, and small bowel transplant also along with the intestinal transplant. So the take-home message is we need to understand better of the metabolism, what is happening, and the pathophysiology of the disease, so that we can give the adequate nutrition and the supplements also adequately. And case-to-case tailored approach is required. And the multidisciplinary team management, which include the dietitian, it include the nursing staff, the physician, the critical care people, anesthetists. There will be a group of team who has to manage these types of critically ill patients. And the correct disease-specific diets has to be required for the proper optimization. And always we have to think about the fluid and electrolyte corrections. Thank you.
Thank you, sir, for your enriching session. Sir, there are a few questions in the chat box.
Okay.
So please see the questions. And also in the Q&A.
1 minute, ma'am.
In the chat box, one question from Jarani Madam. Can you specify nutritional requirements in the mentioned diseases? I mean fat, protein, and carbohydrate intake.
Most of the time we used to give around 45 to 50% from the carbohydrate, 25 to 30 from the fat, and 20 to 25% from the protein. So we prefer like around half of the diet calorie should come from the carbohydrate, except in diabetes, you have to give around 40 to 45, around 40 you have to maintain. Rest of the things, we need around 45 to 50% calorie from the carbohydrates, 25 to 30 from the fat, 20 to 25 from protein. This is for almost all the disease. But in certain diseases like neurological abnormalities are there, then we may have to decrease on the carbohydrates. So in that scenario, you have to go for a ketogenic diets or anything. That high protein, high fat, and low carbohydrate diet. But most of the time, we prefer giving 45 to 50% main source of energy from carbohydrate.
So the second question, in COVID, any supplementation help or protect these patients?
Definitely, vitamin C, immunomodulators can definitely help. Vitamin C, vitamin A, and you have to take vitamin D also. All these micro and macro trace elements like zinc, selenium, and B complex vitamins. All these things will help, and you have to hydrate yourself nicely. And COVID is just like a common fever, so you have to enhance your immunity. and fresh vegetables, milk products, all these things will help you out.
Sir, one more question from Smita Madam. Whether LCHF diet helps to reduce fatty liver?
Low carbohydrate diet, definitely, because thing is like the extra carbohydrate is the that is forming the fatty liver. So you have to decrease on the carbohydrate content, and you have to little bit increase on the protein and very good fat. The thing is like the cholesterol formation, almost 80% of the cholesterol is formed from the extra carbohydrates, not from the fat. So if you're taking extra fat, this acetylcholine cannot enter the gut cycle. So you increase on the fat and the protein and little bit decrease on the carbohydrate diet. And with exercise, you can come out of the fatty acid, fatty liver. So low carbohydrates means it doesn't mean like you have to decrease to very ketogenic diet means less than 50 gram of glucose, but that is not good for the health. We need obligatory around minimum 100 to 150 gram of glucose. That means around 500 to 600 kilocalories should come from the carbohydrate.
One more question. Sir, any specific diet to decrease heartburn? From
Yeah,
Sony Madam.
Heartburn is basically because of our lifestyle problem. What happens is like when you get obese or the abdominal fat is increasing. What happens is like the hiatus will be more, and we need around 3 centimeters of the intrahepatic esophagus to act as a valve. Usually there is no valve. It is because of the three-dimensional muscular activity, the vectors which is acting on, and the valve-like function is happening. So once you are getting fat, you are increasing on the weight. The problem is like the intrahepatic length of the esophagus decreases. So that's why heartburn is happening. So reflux will be very high. So the thing is like regular exercise and the timely food and the things which increase the acid reflux we have to avoid. Like you have to avoid coffee, tea, all these things, chocolates and spicy things and late night heavy dinners. You have to avoid fast food. Everything you have to decrease. You have to decrease on the sugar, all white things, white salt, white sugar. All these white things are not good. All these things you have to decrease. And the morning breakfast has to be very heavy. At least 40 to 50% of the calories should come from the breakfast, and it has to be taken before 8 o'clock. And the lunch should be medium, and the dinner should be very minimal. So what happens is like we have to go for the circadian rhythm only. At 6:37 you have to take the dinner. The problem is like most of our Kerala, what they do is like morning they will skip the breakfast, lunch at particular time 3 o'clock or 4 o'clock they'll take, and the dinner will be very heavy. That's why this GERD is happening frequently now. It's because of the lifestyle. So we have to improve on the lifestyle, and also regular exercise is required. And with acid control for 1 or 2 months, you can come out of it.
Thank you, sir. So by this, we have come to the end of the sessions. Hope these sessions were useful. I take this opportunity to thank all the participants for their patient listening and the esteemed panelists for their magnificent and informative sessions in the midst of their busy schedule. We appreciate your time. Please accept our endless gratitude.
Thank you.
Now,
Thank
I
you
am
so much.
inviting, thank you.
Thank you.
Now, I am inviting Mrs. Lally Paul, Associate Professor and Faculty Coordinator of this webinar, for the vote of thanks.
Good evening to all. Respected Dr. Usha VK, Principal, Government College of Nursing, Kottayam. Madam is very keen and enthusiastic about the academic growth of their staff and the students. I thank Usha Madam for being the backbone and motivating, supporting us to organize the webinar. Dr. Vinitha V. Nair, Consultant Cardiothoracic Surgeon at Caritas Hospital, Kottayam, has consented to take a session without any hesitation when we approached her. Heartfelt thanks to Dr. Vinitha Madam for delivering a very informative and practically useful session.
Thank you.
Nutrition in critical care, critically ill patients. Dr. Murali, a consultant in gastro, onco, HPB and liver transplant surgery at Caritas Hospital, Kottayam. Sir is Dr. Vinitha Madam's husband and he is a renowned surgeon. Amidst his busy schedule, Sir has given a beautiful deliberation on nutrition in specific conditions, which was very relevant in present scenario. Thank for being with us.
Thank you.
I also take this opportunity to thank Mrs. Deepa Merin Kuriakos, Assistant Professor of this college, for taking a leadership and effort in making this webinar a success. This webinar would not have been fruitful without the sincere and heartfelt contribution from the faculty of Medical Surgical Nursing Department of this college. Mrs. Padmini Amma, Dr. Lini, Dr. Betty, Mrs. Smita PV, Mrs. Jayarani, Mrs. Usha Rani, and Mr. Ajish P. Mani. I express my gratitude to all of them from the bottom of my heart. I express my heartfelt thanks to Mrs. Raghiva Nuran, Assistant Professor, this college, for her immense support. I also acknowledge effort put by MSc nursing students in medical surgical nursing first year and second year, especially Mrs. Rashmi, Ms. Rachel Jose, and Ms. Vidya KS in this webinar. I extend my deepest gratitude to all the faculty of Government College of Nursing Kottayam and all the participants who eagerly waited for this session, patiently attending them and making it more interesting and interacting through active discussions. Once again, I thank everyone who has been a part of this webinar. Thank you.
Thank you. Thank you.
Thank you, madam.
Thank you.
For the vote of
Thank you
thanks.
so much.
Thank you.
And thank you, sir. Thank you.
Thank you.
Thank you, madam, for the vote of thanks and for the finest coordination of the webinar. All the participants, please fill the feedback form and submit if you haven't filled already. The certificates will be mailed within the next few days. Once again, thank you all. Stay safe. Have a nice evening. Thank you.
Thank you.
Thank you, sir.
Thank you.
എന്ത് ചെയ്യുമെന്നും പറയണ്ടല്ലോ.
എന്തോ